Hello friends, welcome to the live session of image-based questions and important images. And I welcome you all to the session for today, and let's see who all have joined in. And good evening, Mahalakshmi. So dear students, I hope now that your exam has been postponed, I believe that your preparations are in full gear. All right. So Jency, hello, good evening to you. Now, today we have a session for you people planned in the form of important images that we are going to quickly revise for this session. So, Dr. J and Alageshwar, Fareed, Jenil, Pratibha, Arhan, Priyansh, Jyoti, Manisha, Priyanshu, Babita, Dr. Rafa, everybody, all of you people, thanks for joining in. And I welcome you all to this session. Right. So, previously on YouTube, right, we've had two live sessions already done, right, isn't it? In the first session, we took up clinical MCQs and clinical based discussion, mostly pertaining to the recent exam pattern and the recent MCQs in the, exams, previous year questions. And then in the next YouTube live session, we took up a recall of the 100 important one-liners. So that was a very rapidly done recall. Jency, a very happy birthday to you. And hope this year brings you a lot of good health and all your dreams come true. Okay. Now, the session will be, and Priyanshu, today is your birthday too, so a very happy birthday to Priyanshu as well. Now, the session will last for 2 hours, okay? So, 2 hours minimum. So, I want all your attention. All right, so let's get started. All right, this is the first image. Often repeated question, identify this grip, and then there's a question attached. In a case of transverse lie, what part is palpated in this lie? Yes, so this grip is Leopold's third maneuver, right? This is the third Leopold maneuver. What is this grip called? There's a specific name for this grip. This is Pollock grip, excellent. Okay. Now, in case of transverse lie, what is palpated in this lie? Like somebody said shoulder, Dr. Rafa. Yes, the shoulder would be palpated, but in advanced labor, maybe, when the shoulder gets impacted into the pelvic brim. Otherwise, in transverse lie, this grip is going to be empty. The pelvic grip as well as the Pollock grip, right, in transverse lie is going to be empty, right? You won't palpate anything if it's transverse lie like this. All right, so this grip here would be empty in a transverse lie, right? Now, Bandita, head is engaged or not? Now, head is engaged or not? That's a very interesting question, a very interesting statement that you made. Now, tell me, this Pollock grip only tells you about the lie. The information that it gives you is about the lie, whether the lie is longitudinal or not. It could be cephalic, it could be breech, but it only gives you information about the lie. And yes, Priyansh rightly said, if the head is completely free, in Pollock grip, it is going to be ballotable. If the head is completely free, all right, the head is going to be completely ballotable on the Pollock maneuver or on the Pollock grip. But if you want an exact idea about engagement, if you want an idea about the degree of flexion, if you want to have an idea about the descent, then it is the pelvic grip which gives you information. Pelvic grip gives this information. All right, for that we will have to go for the pelvic grip, which is the fourth Leopold maneuver, in which we use both the hands are used, not just one hand is used. Okay. Now, also please remember that there is a lateral grip. Remember, recall, there is this lateral grip. The lateral grip is going to give us an idea on palpation. We'll get to know which side is the back. Back is on the left side or back is on the right side? Obviously, right? So wherever the back is, the occiput is also going to be on that side only. So the lateral grip gives information about the position. Lateral grip gives information about the position. So these are few important pointers regarding these maneuvers, all right? Okay, now moving on, let's have a look at the next image. All right, so now you have to tell me and fill in the blanks one by one for me here. What is this? This is the image of the pelvis. This is the diagram of the maternal pelvis. Only one side we are seeing from lateral view. So this is the sacrum and this is the pubic symphysis. And this here, this is the plane of the pelvic inlet. Excellent. This is the plane of the pelvic inlet, right? And then this plane here, this plane here, this is the plane of the greatest pelvic dimensions. Greatest pelvic dimensions. And you have to tell me, where is this plane of greatest pelvic dimensions? Which is the most roomiest portion of the female pelvis? It is the cavity. It is in the cavity, right? Now, have a look at this plane. Tell me, this plane, can you see here from the lower border of pubic symphysis, touching and passing through the ischial spines? Of course, these are imaginary planes. I hope you understand that, right? So, at the level of the ischial spines and then going behind somewhere between the junction of the coccyx and the sacrum. What is this plane? This is the plane of, yes, what is this plane? This is the most important plane, let me tell you. This is the most important plane that the baby's head has to negotiate while traversing through the birth canal and while on its way to delivery. Yes, this is the plane of least pelvic dimension. That's why it is so important, because this is the narrowest portion which the head has to negotiate through, isn't it? It corresponds to the region of the mid pelvis, right? Right, Gokul, you're right. Junction of coccyx or sacrum, or depending upon the alignment of the sacrum, it could be S4 or S5 also. And it passes through the ischial spines, right? And this plane here, next one, this is the another plane. This is the plane of the anatomical outlet. This is the plane of the anatomical outlet, and it passes through the level of the ischial tuberosities. It passes through the level of the ischial tuberosities right here, as we can see in the diagram. All right. So now I also want you to remember here that if you look at all of this shaded space, okay, all of this shaded space which I just shaded in green, right, this one here, which is the, see, can you see this space now? The floor of this space is made up of the anatomical outlet, and the roof of this space is made by the plane of least pelvic dimensions. This entire space here is what we call as the obstetric outlet. This we call as the obstetric outlet, okay? And this another shaded region here, can you see here? I am shading it in pink. This shaded region here, which extends from the plane of least pelvic dimensions below to the plane of greatest pelvic dimensions above, corresponds to the region of the mid pelvis. Okay, so these are certain important pointers regarding this diagram on which they tend to ask you questions. All right, now moving on. Excellent. So all of you are pretty well prepared. I can see that. Now, which diameter is being measured here in each of these images? On the left, yes, the first one on the left. Which pelvic diameter is being measured? Image on the left, yes, extending from the lower border of pubic symphysis to the tip of the sacral promontory, from the lower border of pubic symphysis to the tip of the sacral promontory. This is, Raghav, not obstetric conjugate. The only conjugate, the only anteroposterior diameter of the inlet that one can clinically determine is the diagonal conjugate. is the diagonal conjugate, right? So we get an idea about how much the diagonal conjugate measures. It is somewhere around 12 centimeters, and 12 minus 1.5 is roughly equal to around 10.5 centimeter, and that is the obstetric conjugate. Okay. Now, image on the right, which diameter is being measured here? Which diameter is being assessed? Can you see here? 4 knuckles are being placed in between 2 bony prominences while examining the woman. This is TDO, transverse diameter of outlet. We're talking about the anatomical outlet here. This measures around 11 centimeter, and you are right, Palak, this is also called as the intertuberous diameter because it is between 2 ischial tuberosities. So intertuberous diameter. So these are 2 important diameters which we clinically determine. Keep that in mind, right? And another diameter which you guys are talking about, interspinous diameter. Bache, that is the interischial spine diameter, right? And this is something that we all can assess clinically, but we put our fingers inside, and then when we are doing the pelvic examination, we try to touch the ischial spines, okay? And 2 ischial spines cannot be palpated simultaneously at the same time, right? So we get an idea clinically about the interischial spine diameter, okay? So this is here. Interischial spine diameter, IID is here, okay? So important key pointers here. Interspinous or interischial spine diameter, it is the most important diameter of the true pelvis, and I have told you why, because this is the region of the mid pelvis. This is the narrowest portion that the head has to negotiate through. In any given pelvis, this is also the shortest diameter of the true pelvis. These are important pointers to know. And ischial spines correspond to 0 station. Ischial spine correspond to 0 station, okay? When the head comes down below that, it is +1, +2, +3, +4, +5, right? And if it is above the ischial spines, it is -1 to -5 and so forth, like that, okay? So there are some important pointers, quick recall about this level of ischial spines. Key important features. See, engagement, when the head is engaged, right, the station should at least be 0. So engagement occurs at this level. Internal rotation also occurs at the level of ischial spines. The external os is also suspended and held at this level. Pudendal nerve block is also given at this level. The obstetric curve of Caris, okay, that also takes a forward turn at this level. The levator ani are inserted at this level. And another important pointer in gynae, when we go for this vaginal pessary insertion for prolapse cases, it needs to be fitted and suspended at this level of the ischial spines, right? So there are, how many pointers have I given you? 6, 7. I know the entire slide is containing about 10 pointers regarding the level of ischial spines. It is so very important, okay? Now, next slide. What is shown in the figure given below? See, this is the level of the ischial spines. The head has very well crossed the level of ischial spine, and this is baby's ear. So basically what they're trying to show is that the biparietal diameter, this biparietal diameter has crossed the pelvic brim. Okay, this is the definition of engagement. So this image is showing engagement, right? When the head is engaged on PV, the leading point of the fetal skull is supposed to be at least at the level of ischial spines, and per abdominally the head would be palpable 1/5 or at the most 0/5 palpable above the pelvic brim. Now the question here is, what is the most common cause of free head at term? So there are 2 pointers here. One pointer is that by term the head should definitely get engaged, right? In primigravidas it should get engaged. In multiparous women, engagement can happen at the time of labor also, so that's not a problem, right? But if you have free head at term, particularly in a primigravida, what do you start thinking about what could be the possible causes, and I'm talking about the common causes, right? So one thing that you should keep in mind is the possibility of a deflexed head. If deflexed head is given in the question, that should be your answer. Otherwise, look for the possibility of cephalopelvic disproportion, CPD, cephalopelvic disproportion, CPD, right? So these are the commonest. Okay, deflexed head should be a first choice answer. That's why I've written it on top. After that, cephalopelvic disproportion. And yes, of course, there can be polyhydramnios also. Yes, polyhydramnios also can be the reason. And yes, placenta previa can also be the reason. Very good. So all the causes I've got from you as well here. And a contracted pelvis, okay, with cephalopelvic disproportion, you can write contracted pelvis also. So that would also suffice. That would be, I would take it as a correct answer. Short stature by itself, no, I won't say short stature by itself. If with short stature there is some level of cephalopelvic disproportion, then it would be the scenario. And another clinical pointer, you know, sometimes we forget when we examine women full bladder, that can also lead to an unengaged head. So it is better that we examine women after she has emptied her bladder, because full bladder can lift the presenting part up. So one possibility to consider is also full bladder. Okay. All right. CPD, polyhydramnios, common cause of free headed term. All right. So we've got that response from you people, and somehow my pen is not working. Let me just restart this. Just give me a moment, guys. Why isn't my pen working? Can anybody tell me why would my pen not work? You need to charge it. Yes, Philadelphia. It's charged. My Apple Pencil seems to be charged only. I don't know why it's not working now. And on this it is working. Let me see that again. Oh, got it back. Yeah. All right. Coming back. Now, identify the fetal position. Yes, identify the fetal position. Yes, it's a very simple, straightforward. How do you identify? Look at the back side of the fetus, right? Back is on the left side. Okay, whenever we are seeing images, imagine that you're seeing the patient like that. Okay, so this would be, that's why Rajdeep, I said, no, it's not ROA, bacha. You have to look at the image like you are seeing a patient in front of you, okay, not according to your own right. This would be left side of the patient, right? So this would be, obviously occiput is also on the left side, but if you look at this here, this is the occiput. How do we identify occiput? With the posterior fontanelle. Can you see? This is the triangular posterior fontanelle. Okay, so this is occiput anteriorly. isn't it? So this is anterior, this is posterior, this is left side, and this is right side of the patient. So this is left occipito-anterior position, right? The description is also given to you on the right here, right? So you can see here on PV, the occiput is identified by the posterior fontanelle, and you can see that the sagittal suture is directed obliquely. If it was like this, sagittal suture directed transversely, then this would have been left occipito-transverse. Now, the most common fetal position, if they ask you in your exams, right, in early labor, it is LOT, and in advanced labors, it is LOA. It is LOA in advanced labors, right? Now, another important pointer that you can see in this image here, question is engaging diameter of a well-flexed head. So, this is a well-flexed here. Can you tell me what is the engaging diameter? Yes, this is the engaging diameter. This is suboccipitobregmatic diameter. Suboccipitobregmatic diameter, which is 9.5 centimeters. So I want you to remember the diameters that are 9.5 centimeters. All right. One is the biparietal diameter. The BPD is also 9.5 centimeter. Okay, suboccipitobregmatic is also 9.5 centimeter, and submentobregmatic is also 9.5. So where there is bregma na, that is also 9.5. All right. Now, next slide. Identify the position here. Right. Now, this is, who had said ROA? I forgot. Now, this is right. This is the right occipito positions. Okay. So this is, here on the left is right occipito-posterior. Can you see here, occiput is directed posteriorly and sagittal suture is obliquely placed. And here it is right occipito-transverse. Here it is right occipito-transverse. Okay, so on the left is occipito-posterior, right occipito-posterior, and on the left this one is right occipito-transverse, right? Now, another question is that in right occipito-posterior positions, the head tends to be deflexed. Okay, see, most common cause of right occipito-posterior position is android pelvis. Okay, and another reason is the head being deflexed. Another reason is head being deflexed, right? So the question is, what is the engaging diameter of a deflexed head? It could be suboccipitofrontal, and more importantly, it could be occipitofrontal. So that is the diameter that I want you to remember, occipitofrontal, which is much larger, 11.5 centimeter. Okay, it is not like 9.5 centimeter suboccipitobregmatic diameter. It is a larger diameter which is trying to engage. Larger diameter is trying to engage. Understand? So what can happen in occipito-posterior positions? The engagement could get delayed. It may take longer for the head to get engaged. It may take longer for the head to come down and get flexed and descend into the pelvis. So all in all, the labor could get prolonged, right? So head is often unengaged and deflexed. Clinical clues that have been mentioned in the question: infraumbilical flattening on per-abdominal examination can be elicited. All right, very subtle, but it is possible to feel for that. The limbs are felt more anteriorly, and fetal heart sound is best heard at the maternal flanks, right? So here, if it's a right occipito-posterior, it would be the right maternal flank, and so on and so forth. On PV examination, what happens, because the head is deflexed, okay, head is deflexed. So when the head gets deflexed, it is the anterior fontanelle which becomes more easily palpable. So on PV, the anterior fontanelle is felt more easily. All right, so keep these important pointers or clues whenever they put in an image based question on occipito-posterior position. All right, now next flashcard. Now you were talking about mento-vertical, you were talking about bro presentation. Here it is, quick pointers. It could be an image of bro presentation like this. What you can see here, that this region, this forehead wala region is what becomes the presenting part, right? Now the head is in neutral or military position, we call it. It is midway between flexion and extension. All right, and the diameter that is trying to engage is the mento-vertical diameter. This is 14 centimeter. This is very big. This will not be able to enter into the pelvis. The transverse diameter of the inlet is only 13 centimeters. Transverse diameter of inlet is only 13 centimeters. If it remains bro, okay, either it can get flexed, become vertex, or it can get deflexed and become face. But if it remains bro, there is no mechanism of labor happening. So persistent bro presentation in active labor has to be managed by cesarean section. No vaginal delivery is possible, right? And clues could be, yes, on PV examination, what are you feeling? That the head is high up. The head is high up. It is unengaged, right? Free floating head. And on PV, all you're able to feel is the forehead and the supraorbital ridges. So these are 4-5 important pointers regarding the bro presentation. They can come with the image as well. Now, next quick recall of the face presentation, right? So face presentation tends to happen when there is complete extension, or maybe sometimes even partial extension of the head can lead to face presentation. But let's stick to the more common scenario, that is complete extension of the head. Now, when the head is completely extended, can you see this diameter? What is this diameter? Can you see this in the image? So image based recall, this is submentobrachmatic diameter. I told you that this is 9.5 centimeter. This is left mento anterior, right? Mentum, the bony prominence, right? That is defining the position. That is the definition of denominator. We all know that, right? So for vertex, it is the occiput. For face presentation, the denominator becomes the mentum, right? So to say whether it is mento anterior, mento posterior, now we have to look at where the chin is directed. So this is left mento anterior in this image here, right? So as long as it is mento anterior, vaginal delivery is possible, and this image is here to help you remember that face delivers by flexion, right? Face delivers by flexion, head delivers by flexion when there is a face presentation. And also remember that otherwise in vertex positions, how does delivery of the head takes place? By extension. So this is something different. So keep this in mind. Now when it is mento posterior, when the chin is directed posteriorly, either it is directed directly posteriorly or maybe, left side posteriorly, right side posteriorly, doesn't matter. It does not behave like the occipito-posterior position. In occipito-posterior positions, majority of the times, 95% of the times at the most, what happens is good outcome happens. Internal rotation of the occiput occurs. But when it is mento-posterior, it's a different story. When it is mento-posterior, it is very difficult for the good outcome to happen. It is very difficult for, mentum to rotate anteriorly. So if it is persistent mento-posterior position in labor, we give preference to cesarean section because there is no mechanism of labor that can, push. Because see, you can see that the neck is so short. You can just kind of imagine by looking at the image itself that, that the further extension of the baby's neck is just not possible because the head is already completely extended. Right? So with all of these clues, with all of these information, these are the important facts that at the end of the day you have to remember for your exams. All right. Now quickly, next slide, type of female pelvis. Now we all know that the most common type of female pelvis is the gynecoid pelvis. Let's focus on the platypeloid pelvis. Key important pointers. See, this is transversely oval, flat pelvis, right? Now this is the sort of pelvis that is associated with face and bro presentation more likely, right? And it's not like in flat pelvis engagement cannot happen. Engagement can happen, but happens by exaggerated parietal presentation. So come to think of it now, how do I want you to remember it? That is the bottom line, right? What does this parietal presentation mean? See, you have, let's say for example that you have a door that is completely open. Okay, you want to enter into the door, you go straight and you enter through the door. Okay, now I'm telling you that the door is half shut. and you can't open the door. The door is half shut, you still have to go through the door, right? So you will tilt your body maybe like this or maybe like this, and then you will enter and negotiate yourself to the door. That's exactly what happens when the pelvis is flat, right? This is the biparietal diameter, this is the biparietal diameter, this is the sagittal suture. Now the head enters the pelvis, instead of entering straight, it will tilt. So parietal presentation, this parietal bone, it will tilt maybe this side, till maybe this side, right? Whichever ways it finds itself okay to do so, it will tilt, and then it is going to enter into the pelvis. So exaggerated, and that too a lot, it's too excessive, exaggerated parietal presentation. That is how the head tends to engage in a flat pelvis. And Rajdeep rightly said face presentation, obviously there's no skull there in anencephaly, so face presentation will be there in anencephaly also. Next set of pelvis is the anthropoid pelvis. This is anthropoid, AP. This is the only pelvis which is antero-posteriorly oval. This is the only pelvis where antero-posterior diameter is more than the transverse diameter. This is associated with direct occipito-posterior position. It is also associated with face to pubis delivery. And then we have the android pelvis. This is the male type of pelvis. We can see that it is triangular, right? Triangular from posterior to anterior, triangular from top to bottom. So what do we realize? We realize that the outlet in this pelvis is going to be narrow. The interischial spine diameter, right, it is going to be narrow. And there can be prominent ischial spines and everything, right? So the TDO is also small. The subpubic angle is also acute because it is triangular posterior to anterior. Important exam pointers, it is associated with ROP. In fact, it is the most common cause of ROP. It is also associated with deep transverse arrest, right? Because obviously internal rotation, we just discussed, takes place at the level of ischial spines. If the interischial spine diameter is narrow, then the problem that arises is that the head does not rotate, the internal rotation of the occiput does not take place, right? So deep transverse arrest. It is also associated with something that we call as dystocia dystrophica syndrome. Dystocia is for abnormal labor patterns, abnormal progress in labor. Dystrophica is for the, for the pelvis being abnormal, and also women tend to be short height, obese, and with thick and small thighs. And obviously with this kind of pelvis, you can see so many things that I discussed can also lead to increased chances of ending up with a cesarean section for all the reasons that I just mentioned. All right. So these are the important pointers regarding the types of female pelvis which you should keep in mind. Next slide, identify the maneuver for me here, yes, and also make a note of this this clue here, or maybe just an extra bit of information for you guys. So this is the suboccipitofrontal diameter. Suboccipitofrontal diameter that distends the vulval outlet. This is vertex presentation, which is delivery, right? And this is Ridzen maneuver. Very good. This is the Ridzen maneuver. It allows us, so this is the maneuver that we use to deliver the head by extension, right? Because the head has to deliver by extension. So we obtain controlled delivery of head in between contractions, right? So this is basically controlled delivery of head in between contractions. This is what originally Ridzen said, and now we have something called as modified Ridzen, in which we perform this maneuver with contractions. That is the only difference. Okay, that is the only difference. So original Ridzen and modified Ridzen. Just an extra bit of information, don't worry too much. If it is just an image based question, they won't mention the two things together. But yes, what you should know is originally Ridzen said controlled delivery in between contractions, and then modified Ridzen was that something, modified Ridzen says that we can do this maneuver with contractions also. Next question pointer, what are the methods to prevent perineal injury during delivery? Yes, what are the methods to prevent perineal injury during delivery? Yes, perineal massage is there, perineal support is there, right? Okay, and this Ritzden maneuver is also there. What I want you to understand is warm compress is also there. Okay, warm compress is also there. Please remember, episiotomy is not routine. So please remember, episiotomy is not routine. Episiotomy is not performed to prevent perineal injury. Please remember this also. Episiotomies are always indicated. Okay, so keep that in mind. Next, identify the instrument where it is used. So we were talking about episiotomy in the last slide. These are episiotomy scissors. Episiotomy scissors. Okay, what sort of episiotomy we are giving? We are giving mediolateral episiotomy rather than midline episiotomy, right? Mediolateral is preferred. See, mediolateral episiotomy is a kind of a second degree perineal tear. It is basically a kind of second degree perineal tear which we are giving. Okay, so we are cutting the vaginal mucosa, we're cutting the skin, and we're also cutting the perineal muscles in that region. So obviously mediolateral episiotomy is bound to bleed more. It is also going to take longer to heal, right? But yet it is preferable. Why? Because we avoid the anus. Okay, and we avoid the external anal sphincter. So in case the episiotomy needs to be extended or accidentally it extends posteriorly, we want to avoid the anus. So the problem with midline episiotomy is that even if it bleeds less or heals maybe faster, but yet we don't want to give midline episiotomy because we have the external anal sphincter and anus posteriorly. If we are going to injure that, then obviously we can repair it, of course, but it increases the risk of complications and it increases the risk of, anal incontinence and fecal and flatus incontinence at a later point of time if repair is not proper or if repair is not done altogether. So avoid that problem altogether. It is mediolateral episiotomy that is preferable. The timing of episiotomy is as and when needed, but ideally should be at the time of crowning. Ideally at the time of crowning. Is episiotomy a routine? I have already answered that question. It is not routine, right? So Rajdeep, second stage of labor, obviously second stage of labor when you are delivering the baby's head, but even in that, ideally at the time, at the moment of crowning, because when the crowning is happening, the perineum is thin and stretched. Giving the episiotomy is easier also and bleeding is also less. So we try to give it as close to crowning as possible, right? Okay, now moving on, next slide. So this is, again, we'll just quickly go through. This is, you can see, this is the image based question can come often repeated. This is the McRoberts maneuver. See, McRoberts maneuver is done for shoulder dystocia. This is the go-to maneuver. This is the first maneuver that we're going to do, right? How does it work? It rotates the pelvic cephalad, okay, and there is straightening of the sacrum as you can see in these images. In McRoberts maneuver, you can see that there is hyperflexion of the maternal thighs and legs towards the abdomen. Okay, now the assistant is also giving suprapubic pressure. Suprapubic pressure is in addition to McRoberts. So McRoberts mean this hyperflexion of the thighs, okay, thighs onto the maternal abdomen. That is McRoberts maneuver. Additionally, suprapubic pressure can also be given. And like you said here, you are rightly saying myalgia paresthetica. The one complication that this maneuver can result in is injury to the lateral cutaneous nerve of thigh. Now, the lateral cutaneous nerve of thigh, recall from your anatomy, it travels beneath the inguinal ligament. So when the thighs are hyperflexed, right, the lateral cutaneous nerve of thigh can get compressed behind the inguinal ligament, and later on it can lead to paresthesias on the lateral aspect of the thigh, so which we call as myalgia paresthetica. Okay. Now, also please tell me, this is not the most common maternal complication, however, with shoulder dystocia. What is the most common maternal complication with shoulder dystocia? Tell me, what is the most common maternal complication with shoulder dystocia? It is very good, PPH, Rajdeep, very good, PPH. It is postpartum hemorrhage. Okay. And what is the most common fetal complication? What is the most common fetal complication with shoulder dystocia? Most common fetal complication with shoulder dystocia. Don't say lateral cutaneous nerve injury. It is brachial plexus injury. It is brachial plexus injury. When shoulder dystocia happens and we are, kind of pulling at the neck and, grabbing at the baby's neck and stretching it, we're stretching the brachial plexus, right? So, brachial plexus injury, and that can result in Erb's palsy and Klumpke's palsy and different kinds of brachial plexus palsies, right? So, that is the most common fetal complication. What is the sign that is asked in reference to shoulder dystocia? What is that sign called? And I'll give you the sign, all right? I'm just quickly recalling and revising with you. What is that sign called when the head delivers and then, quickly recedes back onto the maternal perineum, right? There's also failure of external rotation and restitution. This is the way that we describe it. So, as the turtle comes out of its shell and then goes back in. So, that is the turtle sign. That is the turtle sign in reference to shoulder dystocia. Excellent. Next slide. Identify the presentation. So, quick recall. I think obviously you guys know this already. This one here is frank breech. Frank breech is a type of incomplete breech. You can see on PV examination just the sacrum and the buttocks will be felt. That's it. Okay. And this one here is complete breech. This is flexed breech. Okay. Now, frank breech is more common in primibravidas, and complete or flexed breech is more common in multiparous women, and in this we can see that the knees and the hips both are flexed. So, on PV examination, when we are doing PV, we'll feel the buttocks also, we'll feel the feet also. And here it is footling breech, right? The hips are extended, the knees are also extended. So, on PV examination, we feel the feet and the buttocks are very high up. So, that is footling breech, right? Now, most common cause of breech is actually prematurity. By prematurity, I mean that most of the time breeches, they tend to revert back to cephalic and spontaneous version happens by the time term comes. But when a woman happens to go into preterm labor, we are more likely finding that we are more likely to find a woman in breech presentation. So, most common cause by that logic is prematurity, right? Otherwise, risk factors are obviously there, like multiparous women, they tend to have more likely probability of having breech presentation. Now, risk of cord prolapse is maximum. Risk of cord prolapse is maximum. See, yes, you are right, Nico, footling breech, but if the option says transverse lie, pick transverse lie as the answer, transverse lie and then footling breech. Okay. Now, among the breeches, the least risk of cord prolapse is with frank breech, So, sometimes they also say this is the safest sort of breech to have as well. Okay, if to have a breech at all. Okay. So, this is about the breeches. Okay. Now, identify these maneuvers. How we are going to identify? Very simple, very simple. Look at where the fingers are placed. Fingers are placed at the groin. This is groin traction. If fingers are placed at the groin, what are we delivering? We are delivering for the buttocks, right? Look at where the fingers are. If the fingers are here in the popliteal fossa, P for popliteal fossa, P for Pinard's maneuver, right? So, look at this leg, this was extended. Similarly, this leg was also extended. So, when we press at the popliteal fossa like this, right, the leg flexes, and then we can grasp the feet and then, bring down the leg. So this is for delivery of extended legs. Okay, now here image is showing you the Loveseth's maneuver, rightly said, Loveseth's maneuver. Okay, so Loveseth's maneuver, as you can see, the shoulders are being delivered, the arms are being delivered. That's what the image is telling you. Supposing there was no image, then when you are in love, you want to hug somebody, and then you put your arms like this, and you want to hug somebody. So that's how I remember it. It is for extended arms, and when arms are going to deliver, the shoulders are going to get delivered as well. So Loveseth's is for delivery of extended arms. Okay. So remember these three images. They can be image-based questions. They are often also asked as a part of match the column kind of questions also. Now, fine. Look at this one here. First maneuver, malar flexion and shoulder traction. Malar flexion and shoulder traction. This is Morisot smelly wheat, right? MSV. Okay, Morisot smelly wheat. Now, what is this here, where we are grasping the baby's feet and bringing the feet towards the maternal abdomen? This is Burn-Marshall's. This is Burn-Marshall. Okay, and this one here on the right, these are specially designed forceps. And unfortunately, I believe you will not have seen Aftercoming head of breech being delivered by forceps in your hospitals, because we don't have these forceps generally with us. And but this, then again, this is for your exams and theoretical questions. So these are Piper's forceps. Piper's forceps, okay, specially designed for Aftercoming head of breech. And remember P for Piper's, remember the pelvic curve in this forceps is absent. Pelvic curve in this forceps is absent. Okay. And one thing before I move on to the next two images, let's just take up this. Aftercoming head of breech engages by, so remember here, look at this, suboccipitofrontal diameter. So the head is also slightly deflexed at the time that the head is engaging. So it is very important and crucial while we are delivering the head that it maintains its flexion. So Aftercoming head of breech engages by suboccipitofrontal diameter and delivers by flexion. So these are other two important pointers that you should remember. Now look at this image on the bottom left. What is this incision called as? An incision given over the cervix. Aftercoming head of breech is stuck. It is stuck behind an incompletely dilated cervix. Then only you give it. Okay. So what is this incision? This is called as the Dushan's incision. Dushan's incision. Okay. Now, remember, as we can see in this image, it can be given at here 2 o'clock, it can be given here also, it can be given at 6 o'clock, but do not give it at 3 o'clock and 9 o'clock position. Do not give it at 3 o'clock or 9 o'clock position. Why? Because of the presence of the descending cervical artery branch there, right? So we don't want to cut that branch, obviously, otherwise it will lead to a lot of bleeding, right? Now, the image here on the bottom right, this is the Prague's maneuver. This is the Prague's maneuver, right? And again, this is the Aftercoming head of breech, but the difference is the back is posterior. This is dorso-posterior. Back is posterior, right? So this is Prague's for delivery of Aftercoming head. Delivery of Aftercoming head, but it is dorso-posterior. Back has gone posteriorly. Okay. Next image. Following maneuver is used where? Now this is transverse lie, but this is maneuver is not done for all transverse lies. Okay. Please remember this. Transverse lie in labor, we do a cesarean section, right? This maneuver, this is internal podalic version. This is internal podalic version. The only place in entire obstetrics where this is practiced is delivery of second twin, not not even the first twin, okay, delivery of second twin in transverse lie. That is the only place where this is done. So the feet are grasped, okay, and then we bring down the feet. So we bring down the feet and then deliver the rest of the baby as breech. That is what is done in internal podalic version. Okay. Next image, identify the maneuver. Pointers regarding the maneuver already given to you. This is also called as modified Brand-Andrew method, right? And this is a maneuver that we do to deliver the placenta. Okay, and it is only done when the uterus is contracted. That is also an important pointer. So this is controlled cord traction. The traction is applied in two directions. One is upwards towards the umbilicus right here, and downwards and forwards, right? That is the traction on the cord, right? So this is controlled cord traction, controlled cord traction. And yes, this is part of AMTSL also, right? It has to be performed only by trained personnel, right? So trained people who are trained in performing deliveries and help perform the reason that it is also important to perform this maneuver only during uterine contractions is because we don't want to pull at the cord when the uterus is relaxed. Otherwise, it can result in uterine inversion. So how does this maneuver help in preventing uterine inversion? Because one hand is giving counter traction in the upward direction, right? It is giving counter traction in the upwards direction, and at the same time, with that hand, we can also feel for the uterine contraction. So we are sure that we are pulling at the cord only when the uterus is contracting. So when properly done, this maneuver is going to help prevent uterine inversion. It is the recommended method for delivery of placenta. Okay. Now, next image, identify the techniques and where they are used. So, all of these techniques are used in one place. That is why all of them are together. But let's identify. Image on the left. This is a specially designed balloon. This is a specially designed balloon. What is this? Yes, you're right. All of these procedures are mentioned and are done in atonic PPH cases, right? So this is a specially designed balloon. What is this specially designed balloon? Bakri balloon. Bakri balloon. This has a capacity of 500 ml. It is filled with saline. It has also got a draining port. So if any blood is collecting inside the uterine cavity, that will also come out, right? It will not allow blood to collect inside the uterine cavity also. So it has a drainage port. So this is a specially designed balloon. Many times it's not available. So we often at times in low resource setting do some kind of jugaad, and that is what we see on the image on the right here. What do we see? This is a condom catheter. This is a condom catheter, right? Will serve the same purpose for us. Now this image here on the right, this is bimanual uterine tamponade, bimanual uterine tamponade. So can you see where when we are doing the tamponading thing, right, the bleeding happens from these, open sinuses because the uterus is not contracting, it is atonic. So we are trying to tamponade it, we are trying to close off those sinuses, one. And secondly, when we are tamponading, we are also trying to rub up a contraction, right? So this is how this bimanual tamponade helps. Now come to this image. We can't keep doing the tamponade all the time. So either the tamponade works and meanwhile the uterotonics works, and maybe we can try for this Bakri balloon and condom catheter to achieve the same kind of tamponading effect from inside the uterine cavity. If that works, fine. Otherwise, we are left with doing this tamponade surgically. Technically, we are doing the tamponading only now. We are placing a suture and we are, tamponading the uterus. That's exactly what we are doing by applying this suture. These are what we call as uterus compression sutures. Uterus compression sutures. They look like braces, right? That's why brace sutures also they are sometimes called as, and this one is typically B-Lynch suture. Okay, most of the times your images will be around B-Lynch suture. The reason why they tend to ask B-Lynch is because we do B-Lynch, all right? Otherwise, there are different kind of sutures here. The Heyman sutures, the Cho square sutures, the different kind of uterine compression sutures used differently, right? And this one here is the B-Lynch suture. All right, so these are all preferred, these are all methods that have been used or techniques that are used in atonic PPH cases, right? Okay, next image. Next image, identify the procedure. Okay, identify the procedure. See, clue, site 5 centimeter distal to the bifurcation of the common iliac. So this is the common iliac artery, this is the common iliac artery, this is external iliac, and this is the internal iliac. So what is this? Which artery is ligated? Internal iliac artery ligation. Internal iliac artery ligation. And we want to ligate the anterior division of the internal iliac artery, right? Important pointer, the posterior division is spared. Why? The posterior division needs to be spared. This posterior division needs to be spared. Why? Because it will give a terminal branch, the superior gluteal artery. It will give a terminal branch, superior gluteal artery to the buttocks, right? So if accidentally we kind of, maybe place it incorrectly and we compromise the blood supply to the posterior division of internal iliac artery, it will lead to ischemic pain in the buttocks. Right, buttock claudication, ischemic pain in the buttocks. We do not want to deprive the buttocks of the blood supply, right? So that is why the posterior division needs to be spared. Now the principle why this procedure works is that when we put in a ligature here, all right, the blood flows distal to the ligature. Distal in the anterior division of internal iliac artery branches, it slows down. The pulse pressure decreases by about 85%. It becomes like a venous circulation, characteristics of a venous circulation, slow flow, and that promotes coagulation, thrombosis in the distal circulation, and that is the principle of this procedure. Remember that. Now also you can understand that yes, we have this procedure mentioned in PPH cases also, right? And understand here that logically speaking, any gynae surgical procedure also where I want to stop bleeding from the uterus, okay, remember it like that. When you want to stop excessive bleeding from the uterus, this kind of procedures, which are the ligation procedures, stepwise devascularization procedures, they can be used, right? Now where you have read about it is in, again, PPH cases, okay. So what are the arteries involved in stepwise devascularization? Another question. J. Vyas, do we completely stop the distal circulation or partially? No, we don't completely block it. Okay, we don't cause ischemia to the uterus. Otherwise, again, no. And collaterals open immediately. Collaterals open soon after the ligation. So uterus doesn't become ischemic, but it just gets like that breather or that opportunity, because in the distal circulation, coagulation occurs, so bleeding can be controlled. That doesn't mean that, the primary source of bleeding should not be targeted. Okay. Fine. Now, yes, so stepwise devascularization, first uterine, then ovarian, and then internal iliac. Right, very good. So this is the sequence, okay. Now, moving on. Next, identify the procedure. So what you can see here, that this is an interventional radiographic procedure. Right, polyvinyl alcohol particles are introduced via the femoral artery, and then what is cannulated from the femoral, then back to the external iliac, and then all the way to the uterine. This is uterine artery embolization. Very good. This is uterine artery embolization. Okay. Now, understand, you ligate the uterine artery surgically, right? Tie it up to decrease the blood supply to the uterus. And now technically you're doing the same thing, but now you're doing it, you're avoiding a surgery. That's what you're doing, right? Isn't it? You're avoiding a surgery. That's what you're doing. So when the emergency is there, when the patient is hemodynamically unstable, you can't really rely on uterine artery embolization, because this procedure A will take time. This procedure A will be also need an interventional radiologist in place, right? So in the face of an emergency, in a patient who's like really bleeding, all right, in a patient who's already on table open in front of us, this procedure will not make sense, right? So uterine artery embolization can only be considered as far as stable patients are concerned, okay, hemodynamically stable patients, and not actively bleeding heavily, right? So In the context of PPH I'm talking about, in the context of PPH I'm talking about. But if you look at this image here, uterine artery embolization has also got a role in, what is this? This is a fibroid. So deprive the fibroid of its blood supply and avoid the fibroid from growing. Shrink the fibroid by depriving the fibroid of its blood supply. So this has been a potential, it is a potential treatment strategy for fibroid uterus cases also, and I won't go into too much details right now, all right, because there's only certain specific kind of fibroid cases where this becomes useful. But the important thing to remember is that this is a this procedure would be only and only done for women who otherwise are surgical candidates. Okay, they are so troubled with the fibroid, they have heavy bleeding, they are symptomatic, all right, and they need a surgery. Think about it like that. They deserve some definitive treatment, but for some reason surgery cannot be done. Surgery is not the choice for them. Maybe they are unfit for surgery, maybe they are not willing for surgery. So this can be considered as an alternative to surgery, but only when surgery is not for some reason possible. So if surgery needed but not possible, so it will not be the first line treatment strategy any which ways. Secondly, this will not be an option. This will not be an option for women who want fertility. For women who want fertility. Please remember this also. All right, I have written it down in the slide, maybe not be visible to you, but no, see, Sangeeta, it leads to infertility. That statement would be not be entirely correct. How it affects fertility is something that the studies have shown that it may decrease or it may decrease the potential of future fertility, okay, because when we are, embolizing the uterine artery, who knows that some of those polyvinyl alcohol particles, these are all really rich anastomotic network. Some of those particles will go to the anastomosis between the uterine and the ovarian, and then hamper the blood supply to the ovarian also. So how it will affect fertility, or maybe detrimental to fertility, is what I would like to say. So it will not be an option for women who want future fertility, right? So these are the 4 important pointers you need to remember from this image. Now identify the type of placenta here. Cord is attached to the margin of the placenta. If associated with low implantation of the placenta, meaning low lying placenta or a placenta previa, there is a chance that the cord may get compressed during vaginal delivery, right? Most of the times this doesn't happen actually, but this is a battledore placenta. This is a battledore placenta. Yes, this is marginal cord insertion. This is marginal cord insertion. All right, next image here. Yes, image on the left, first image on the left, there is an accessory lobe. There is an accessory lobe which is connected to the main placenta by a leash of connecting vessels, right? What is this? This is called as succenturiate placenta. Excellent, right? Sometimes there may be an accessory lobe but without any connecting vessels. That is called as placenta spuria. The clinical significance, this extra lobe may be accidentally left behind during placental delivery, and it can lead to retained placental lobe that can lead to PPH. All right, and at a later point in time it can also lead to uterine subinvolution if small fragments of these accessory lobe are left behind. They can get infected, can cause infection and polyp formation. Second image, this is when you have an additional lobe, but they are of the same size, almost of the same size. Now the umbilical cord could be attached to one, or it could be attached in the center here also, okay, depends. And there will be a leash of connecting vessels also. This is bilobed placenta. This is bilobed placenta. Okay, and image on the right here, extreme right, you are right, all of you are right, this is circumvallate placenta. Okay, in the circumvallate placenta you can see this thick yellow thick yellow margin, right, and this is the double fold of chorion and amnion. This thick yellow margin is the double fold of amnion and chorion. Okay, so what happens in this? It is circumvallate, chorionic plate is smaller, and it has its own set of complications. It is associated with increased risk of abortion, antepartum hemorrhage, fetal growth restriction, and the risk of preterm birth is also increased when there is a circumvallate kind of placenta. Okay, yes, it can lead to placental abruption also. Babita, you are right. So that's why I said APH. Okay, so placental abruption, you are right. Next image. Yes, here what can we see? We can see that the umbilical cord is attached to the fetal membrane. Such kind of cord attachment is more commonly seen with twins and placenta previa. These umbilical vessels here, they are, can you see here, they are traveling naked in the fetal membranes. They are devoid of their protective covering. What is the protective covering of the umbilical cord? It is Wharton's jelly. So these are naked fetal vessels devoid of their protective covering of Wharton's jelly. That's why these umbilical vessels are prone to compression by the fetal part. They can lead to fetal hypoxia. Another thing can happen is that when we're trying to deliver such sort of a placenta, the umbilical cord can simply get avulsed and then can lead to PPH. This is velamentous cord insertion. Velamentous cord insertion. Very good. Image on the right. Image on the right, these naked fetal vessels, this portion here is here. Can you see? Yup. This, oh, this portion of this portion of vessels or this portion of membranes is here. So it can be associated with velamentous cord insertion also. It can be associated with succenturiate placenta also. Such kind of a situation where naked fetal vessels traveling in the fetal membranes come to lie in front of the presenting part is called as Vasa previa, vessels in front of the presenting part. These vessels, please remember, are naked fetal vessels. These naked fetal vessels are there because there may be a velamentous cord insertions or there may be a succenturiate placenta. So Vasa previa can be associated with these two conditions. Also increased risk with placenta previa. Vasa previa also increased risk when there is a placenta previa at the same time, right? So the risk is that as and when the patient would go into labor, the cervix would open up, the membranes would rupture, and then there will be bright red bleeding, and this bleeding would be fetal bleeding, and there will be sudden, massive fetal distress. Most of the times the fetal distress is going to be so significant, so sudden that we'll end up doing a cesarean section. Okay, yes, but there may be times in my practice, I've never had that time, first of all, to do this apt test, okay, but then for theoretical purposes there is an apt test. There is an apt test which can qualitatively differentiate between whether the bleeding that is happening is fetal blood or maternal blood. So if that sort of a doubt exists, one can do a bedside test, but most of the time in clinical practice such opportunity does not arise. But yes, apt test, they ask you this question in reference to Vasa previa. Apt test is a qualitative test. It only tells whether the blood is fetal blood or maternal blood, right? And there is a quantitative test. What is that quantitative test? When we find fetal blood in fetal RBCs in maternal circulation to detect feto-maternal hemorrhage, that is KB test, okay? So remember, apt test different, qualitative, and KB test, Kleehor-Betke test, quantitative. Okay, so we take the maternal blood sample and can check the fetal blood cells in the fetal RBCs in the maternal blood, right? So we can quantify the amount of feto-maternal hemorrhage. We can quantify by formulas in ml how much feto-maternal hemorrhage must have taken place. That sort of quantitative testing is KB testing, Kleehor-Betke testing. You read about that in RH affected pregnancies. Okay. Next image, yes. So these images, sort of these images were asked in your recent exam also, and the clue is obviously given on the side here. What sort of a placenta is this? What sort of a placenta is this? Yes, can you see here? Now in this image on the left, what we are seeing is that the moment we opened up the woman's abdomen, no, this is what we found. This highly vascular, this placenta infiltrating into the myometrium all the way up to reaching to all the way up to the serosa, right? And this was anterior also in the lower segment, right? And then you know, we done a hysterectomy for this patient after delivering the baby, and look at this, you know, this is placenta that we were not able to separate only because of all of these reasons, as has been mentioned in the slide for you people to remember, right? So this is morbidly adherent placenta, right, which we now call as the placenta accreta spectrum, so this is normal here, right? This is accreta. Accreta means it is just attached to the myometrium. This is most common in 80% cases, it is accreta. Then this, it has gone into the myometrium, it has gone deeper into the myometrium, so it is increta, another 15%, right? And then you have percreta, it has perforated the myometrium, and now reaching all the way up to the serosa, could even perforate the adjacent bladder or adjacent nearby structures. So this is percreta, only seen in about 5% cases, right? So this morbidly adherent placenta results in failure or incomplete separation after delivery of the placenta, right? So when the placenta separates incompletely, it can lead to massive hemorrhage, right? And it will be identified during manual removal of placenta when the plane of cleavage for placental separation is not found, right? Now ideally such patients, if we have an antenatal diagnosis, see, antenatal diagnosis is possible, yes, right? And 3D USG is, or USG by Doppler, USG with Doppler is the investigation of choice. It is the first line investigation that is done. Okay, if ultrasound Doppler is not giving us information, if we have doubt, we can do MRI also. MRI is also very good, but MRI, because it is expensive, it's usually not the first line. Nowadays first line is Doppler ultrasound, right? So if I know already, if I have an antenatal diagnosis, such patients are planned for elective cesarean section, right? And at the same time we perform hysterectomy. So with antenatal diagnosis, elective cesarean section is planned anywhere between 35 to 37 weeks, right? Followed by cesarean hysterectomy. We don't try to separate the placenta, okay? We counsel the woman accordingly. This is the standard treatment, okay? This is the standard treatment, okay? Please remember, and we do not try to remove the placenta also. We do not try to remove the placenta, because if you are going to try to remove the placenta, we will be removing it in bits and pieces, will be causing more hemorrhage only, right? Now, other important question pointers which were left, there is defective development of, you can see this, can you see this here? This is the decidua basalis. Normally it is there, but in the rest of the images you did not see it. So there is defective development of Nita bush layer, which prevents deeper penetration of the placenta, and there is partial or total absence of the decidua basalis. There is partial or total absence of the decidua basalis. All right. So these are the key important pointers with the set of these images. Next images, next set of images. Now these are ultrasound images. For clues, I have the diagrammatic images also on the same side. Before I talk about the images on the left, I want to talk about the image on the right. Okay, so this is very early pregnancy scan. I believe this scan must have been 6-7 week scan. Okay, there are two separate gestational sacs. Two separate gestational sacs all together. Very early pregnancy. Right now the placenta is not even developing and we can't even see a fully formed placenta. So two separate gestational sacs or two separate chorionic cavities. This is dichorionic, diamniotic. right? Now, the chorionicity scan ideally is done between 10 to 14 weeks. Ideally is done between 10 to 14 weeks. Okay, should be done definitely before 10 to 14 weeks. Now, what can happen is, see, if there are two separate placentas, on scan, it is obviously dichorionic diamniotic, right? If there are two separate placentas, it's definitely dichorionic diamniotic, right? But if there is a single fused placenta, then what do we see here? See, this is the placenta, okay? In this image, there is an intertwin membrane. Yep. There's an intertwin membrane, can you see? And this is the placental tissue, the chorionics tissue dipping in the intertwin membrane. So this is here. This is the lambda sign. This is the lambda sign, also called as the twin peak sign. So can you see here? Lambda sign, twin peak sign. Intertwin membrane is also thicker, has 4 layers, 2 amnion, 2 chorion. So this is dichorionic diamniotic, right? Image, lower image, can you see here? Look at the intertwin membrane. Look at the diagram and try to compare. See, intertwin membrane thinner, only 2 layers, and this is no dipping chorion. Can you see here? This is the placenta, T sign, no dipping chorionic tissue. So this is T sign, this is monochorionic diamniotic. This is monochorionic diamniotic. In monochorionic monoamniotic, intertwin membrane will not be there. In monochorionic monoamniotic, there will be no intertwin membrane. And don't worry, there will not be an image for this, because an image where nothing is there, where there is no, how will they ask you to identify something that is not there, which is not seen? So in monochorionic monoamniotic, there is no intertwin membrane. That's just an extra bit of information, right? Next question, next slide. Okay, now the placental images of the twins. Okay, right? Now look at this here. This is amnion. This is amnion, this is the chorion in between. And you can also see 2 separate placentas also. This is dichorionic diamniotic, right? This is a single fused placenta, and the intervening membrane is very thin. It is not, we are not able to separate it. Okay, we are not able to separate it and not able to find a chorion in between. So this is monochorionic diamniotic, and here you can see there is no intertwin membrane. This is monochorionic monoamniotic, right? So placental images of the twins is also an important image based question. It is an important image based question. All right. Now, next image, identify the twin complication. So you can see here, what is this? This is twin to twin transfusion syndrome. This is twin to twin transfusion syndrome. So this could be an image based question also, where one twin is larger, as you can see, the other twin is smaller, as you can see, right? So this is the recipient twin, this is the donor twin. The donor twin is stuck in a corner, right? There is deep artery to venous connections. There are deep artery to venous connections here. So one twin is bleeding into the other twin. So the donating twin obviously will become anemic, will become growth restricted, oligo, and will have renal failure. The recipient twin will get all the extra blood, right? Polycythemic, plethoric, will also have polyhydramnios, will get all that extra blood which the heart will have to take care of, pumping that extra blood, cardiac failure, right? Hydrops can happen in both. Hydrops can happen in both. Cerebral palsy can happen in both. Cerebral palsy can happen in both. Okay, Hydrops can happen in both, cerebral palsy can happen in both. And why is it important? Because apart from image, okay, this is a question, or this is twin to twin transfusion is something that they tend to ask you in a little bit more detail, okay. There is a grading of severity which is called as Quintero staging. It is not very necessary to remember the detailed staging, but please remember at least this much, that what do we see in Quintero staging? We see whether there is oligohydramnios or there is polyhydramnios, right? What Doppler changes are there in the twins. At least we see that whether there is any hydrops in either of the twin, right? So these are the main things that we see in Quintero staging. So basically this Quintero staging is done by using ultrasound and Doppler on the fetus, right? While we are doing the ultrasound and Doppler for the fetus. And fetoscopic laser ablation is the ideal treatment, and many times such ideal treatment is not ideally available all the time, but yes, this is, if this treatment is available, this is the ideal treatment. Fetoscopic laser ablation of the placental anastomosis to be done for severe TTS anywhere between grade 2 to grade 4. Nico, donor twin saved, recipient twin is reduced if surgery karna pade to. See, those are decisions which can be taken much later, where you say that selective feticide, that means one twin is sacrificed. So yes, generally the recipient twin is sacrificed, right? So that is also there, but again, those kind of strategies are not the standard strategies, okay. Now image here, what test is the woman undergoing? Yes, what test is the woman undergoing? Let me give you a clue, okay. First of all, you can see here that she is pressing some button with her thumb here. Okay, she is holding on to something. Now there is a cardio probe. This is the toco probe. Okay, this is the toco probe, and this is the cardio probe. Toco probe is placed at the fundus. All right. Now this is the fetal heart rate trace. Okay. If they are not mentioning anything about contractions, okay, if they are not mentioning anything about contractions, if there are no contractions, if the uterus is relaxed, that means there is no stress of contractions, it's the non-stress test. It is the non-stress test, okay, fine. CTG is cardiotocography, okay. You people get confused because you feel that CTG is something entirely different. See, what happens is, it's the same machine, it's the same setup, it's the same principle, okay. Cardiotocography, analyze in a graph the fetal heart rate trace, that is cardio, and then the contraction trace, that is toco. Same machine, same graph, right? But when the woman is not getting any contractions and she is relaxed and you're doing it as a part of antepartum fetal surveillance, it is the non-stress test, okay. The same equipment, the same set of thing, you do it in your labor room when the woman is getting contraction, she is in labor. It's something that we call as continuous cardiotocography, right? So they're also analyzed similarly, okay, they're also analyzed similarly, okay. So this specifically here is the non-stress test, right? And we also analyze them similarly. I mean, we see the baseline fetal heart rate, okay. Baseline fetal heart rate should be between 110 to 160 beats per minute, okay. We see this wiggliness of the baseline, we call it beat to beat variability, should be between 5 to 25 beats per minute, right? Accelerations should be present, it is a good sign, all right, and there should be no decelerations, So you can see here, this is an acceleration, this is an acceleration, this is also an acceleration, right? So acceleration is 15 beats per minute, a spike of 15 beats per minute, at least lasting for 15 seconds. Okay, that is the definition of acceleration. So there should be at least 2 such accelerations in 20 minutes, then we say that the NST is reactive. 2 such accelerations in 20 minutes at least. And this criteria for acceleration, 15 beats per minute at least lasting for 15 seconds, is for pregnancies that are beyond 32 weeks. If it is less than 32 weeks, then we take the cutoff as 10 beats per minute and 10 seconds, all right. But mostly in your exams, they're talking about pregnancies beyond 32 weeks. So remember at least 15 beats per minute and at least 15 seconds, all right. So this is about the NST strip, and as you can see in this image also, it is a reactive NST. Okay. Now, identify the type of deceleration and what do they signify. So now this is a CTG trace for a woman in labor. You can see that she is getting contractions here. This is the contraction trace. This is the contraction trace. And you can see here that this deceleration in the fetal heart rate, this drop in the fetal heart rate is very smooth. Okay, happens over a period of time, very smooth curve, right? And it is a mirror image of the contraction. Okay, it is exactly a mirror image. So this is early deceleration. Yes, this is also called as type 1 deceleration. And what do they signify? Fetal head compression. So they are because of vagal stimulation. As the fetus's head get compressed. Why does it get compressed? Because contraction, head push down, head get compressed, vagal stimulation, head fetal heart rate drops, contraction getting over, compression getting relieved, head compression getting relieved, fetal heart rate returning to baseline. So this is vagal stimulation. So this is fetal head compression related. So if in a CTG trace the only problem is early deceleration by themselves are not ominous, they are not threatening, they are not very dangerous. Next image, identify the type of deceleration. Can you see here? This is the contraction and look at this deceleration. Can you see the drop in fetal heart rate? The lowest point in fetal heart rate came when the contraction is actually over, or when the contraction is trying to get over, right? So it is delayed. There is a delay in deceleration. It does not coincide with the contraction. There is a delay. So this is what, look at this here. Look at this here. There is a delay, all right, with the contraction. So this is late deceleration, also called as type 2 deceleration. As and you can see in the question, the clue is it can be seen with fetal hypoxia and uteroplacental insufficiency. So when you remember this, you can remember what are the circumstances in which you will encounter fetal hypoxia, or maybe you can encounter fetal hypoxia, or you can encounter uteroplacental insufficiency. Like in fetal growth restriction, there will be more likely chances of encountering uteroplacental insufficiency. Like pregnancies complicated by hypertensive diseases, more likely to encounter uteroplacental insufficiency, right? Or anything that is causing sudden maternal hypotension, that could be because of hypovolemia or blood loss, right? So when the woman is bleeding, she is having placental abruption, you can find such deceleration. When the woman is dehydrated, so severely dehydrated that she is having hypotension, it can lead to such deceleration. When a woman is given epidural analgesia, right, and without any IV fluids and anything, without taking care of her fluid status, and she's having hypotension as a side effect, right, she can have uteroplacental insufficiency, and you can find such deceleration. So the reason is this, and the clinical context in which these decelerations can be identified, I have mentioned, right? So you don't have to mug this up. You understand what these decelerations are. These are chemoreceptor mediated. These are chemoreceptor mediated. Remember that, chemo, hypoxia, right? So they are picking up the low oxygen tension and more of carbon dioxide in the blood of the fetus. So chemoreceptor mediated. Remember it like that. Next image. Okay. Now, identify the type of deceleration. Can you see here? The deceleration is not related to contraction in any way. It could, by meaning not related to contraction, meaning it could come with contraction. It can come before, after. It is unrelated to contraction, okay? And you can see that there is it falls very rapidly. Okay, it reaches the lowest, meaning there's a way sharply it descends down. Okay, within 30 seconds the fetal heart rate drops down to its lowest point. This kind of deceleration is called variable deceleration, and repeated pattern of such decelerations are associated with all except fetal head compression. So basically they are due to cord compression. They are due to cord compression. They are baroreceptor mediated. They are baroreceptor mediated. Now the risk of cord compression is more likely when there is oligohydramnios, isn't it? Post-term pregnancy gets complicated with oligohydramnios, so more likely associated with cord compression, right? So in this question, so this is the way that these questions can be asked. Like it can be an image based question like this, or it can be just an image to identify these decelerations also. Next image, identify the fetal heart rate pattern. Now here you see that there is no beat to beat variability. It's not the baseline that you see normally, which we saw first in the reactive NST. This is sinusoidal baseline. This is sinusoidal baseline. There is a typical sine wave pattern of about 3 to 4 cycles per minute, right? And it is seen with severe fetal anemia or severe fetal asphyxia. So this is definitely not normal. Severe fetal anemia or severe fetal asphyxia. Now the context of fetal anemia. Remember fetal anemia. So there can be, yes, bleeding Vasa previa. Bleeding Vasa previa. The context of fetal anemia could be RH affected fetus. Fetal hemolysis, sudden fetal anemia in that context, sudden fetal maternal hemorrhage, sudden feto-maternal hemorrhage, sudden intracranial hemorrhage in the fetus. All these 4 conditions that I mentioned to you, they are causing sudden fetal anemia only. So remember that as sinusoidal baseline. Okay, fine. Now, next image, complete mole. No, so this is, we'll quickly go through these images because there's not much to discuss. Images along with these, the key important pointers that you need to remember, they are already mentioned. So in gross image is on the side so that you can remember. So grape-like vesicles, there's complete hydropic degeneration of chorionic villi in complete mole, right? And there is no fetus. There is no fetus. All right, and this is on ultrasound the classic snowstorm appearance. Now complete mole is mostly they are monospermic. Okay, one sperm fertilizes an empty egg. The entire genetic material is paternal. There's no maternal, no maternal nuclear DNA. So how can a fetus form? Okay, most common karyotype is 46XX. This is a direct MCQ pointer. Okay, and they are diploid. They are diploid. Most common karyotype 46XX. Next image of partial mole. So in partial mole, we see a fetus that is abnormal. A fetus that is dead, or most of the times it is dead already, and there is a hydropically degenerated placenta, which placenta is definitely there, but cystic placenta can be there. Some degree of hydropic degeneration is there. On ultrasound, we can see a fetus. We can see a fetus which is already dead. We can see a placenta, cystic placenta. Such patients are usually misdiagnosed as missed abortion on ultrasound. Final diagnosis will only be possible by histopath. Now partial mole, they are dispermic, the extra genetic material is paternal, and they are triploid. The most common karyotype is 63XX. Okay, so these are important pointers regarding partial mole. So from the image, these questions can also be asked. They may also give you a clinical profile of a complete mole and ask you what is the management. The treatment of choice is suction and evacuation. The treatment of choice is suction and evacuation. When we have partial mole cases, partial mole, first of all, they are not very common as compared to complete mole. So mostly they will not ask you about the management of partial mole. But if you think about it, generally patients are misdiagnosed and missed abortion. How do we end up diagnosing partial mole? When we send the products of conception for histopath analysis, that is how we tend to pick up partial moles most of the time. Okay, next image. Now on the left here, now these are certain images which I need you to recall for your exams, right? So image on the left, we are seeing a true gestational sac. Now how do we identify a true gestational sac? See, this is going to be the first ultrasound sign of an intrauterine pregnancy, because there will be a double decidual sac sign. Can you see here? There will be these two concentric white rings. Okay, this is because of the decidua paritalis and the decidua capsularis, all right. On the right side, what you are seeing is a gestational sac, but the mean sac diameter they are mentioning in the image is 27 mm, and yet there is no fetus inside, yet there is no fetal pole with cardiac activity inside. So when the gestational sac has crossed more than 25 mm diameter and there is no embryo inside, it is what we call as anembryonic gestation or blighted ovum, or we can call it as early pregnancy loss. Okay, ultrasound diagnosed early pregnancy loss. Okay, and another way to diagnose early pregnancy losses, when CRL is more than or equal to 7 mm and yet there is no cardiac activity. That is also one way to diagnose early pregnancy loss. So we can have situation of early pregnancy loss, situation number 1, where there is an anembryonic gestation or blighted ovum. Okay, situation number 2, when you have a fetal pole which is more than 7 mm in CRL, but yet there is no cardiac activity. So these two situations can be there for ultrasound diagnosis of early pregnancy loss, which is also what we call as missed abortion. Image on the right is showing a double bleb sign. So you can see this is the gestational sac, and inside that gestational sac basically means chorionic cavity. That is what gestational sac is. So inside the gestational sac, inside the chorionic cavity, there is another sac which is the yolk sac. So yolk sac inside the gestational sac, yolk sac inside the chorionic cavity is the double bleb sign. If they ask most definitive as well as early ultrasound sign of intrauterine pregnancy, it is double bleb sign. Other images that you need to remember, very, very important, is this crown rump length. Can you see this crown rump length here? This is the CRL. CRL is the crown rump length. As you can see here, it is measured in the mid-sagittal plane. The neck is in neutral position, right? Overall, this is the best parameter for gestational age estimation. The earlier it is done, the better. CRL can be used till 14 weeks, but it is best measured between 7 to 10 weeks, okay? Now, next we have the biparietal diameter. Images are given to you. You can see the fetal's head. You can see the fetal head. This is the head circumference, and this is the biparietal diameter being measured. This is for gestational age estimation in the second trimester. Then we have the femur length. Femur length is for gestational age estimation, most reliable in the third trimester. And abdominal circumference. See, this is the abdominal circumference that is being measured. Okay, so abdominal circumference is measured is in the transverse plane. Okay, so you can see here there is the stomach bubble, there is the umbilical vein also, there is aorta also. In that plane we measure the abdominal circumference, and it is the most sensitive parameter for fetal growth. When you say single most sensitive parameter for fetal growth, it is abdominal circumference. So remember these key pointers. Don't worry, I will share these slides with you. So all these flashcards, you will have them handy for quick recall. Next image, you can see this is the NT being measured. Can you see here? This is the NT being measured. This is the nasal bone being shown here. So absent nasal bone is abnormal. Nasal bone should be present. Question is, what is NT? NT stands for nuchal translucency. NT stands for nuchal translucency, and it is seen in the first trimester. It is done between 11 to 14 weeks, right? And it is a component for which screening test? It is a component of first trimester combined screening. First trimester combined screening. NT that is more than or equal to 3 mm is considered as abnormal. Is considered as abnormal, right? Now, NT alone is used for screening aneuploidy in multiple pregnancy. This is a very interesting and important point. See, when you have multiple pregnancy, then you cannot rely on the biomarkers. You cannot much rely on the serum markers. Okay, why? Because we do not for sure will know which twin is contributing to those serum markers, isn't it? We are measuring from maternal blood sample serum markers of, you know, all of these quadruple test and triple test and dual test and everything. Those markers are not very reliable, but each of the twin NT can be measured separately. So this will become more reliable for screening for aneuploidy in multiple pregnancy. Right? Next image, identify the fetal anomaly. Yes, we have a venolymphatic malformation. So this is different from the nuchal translucency. You may think it is looking similar. Please don't get worried. They will not ask you to identify whether this is nuchal translucency or this is a venolymphatic malformation. They'll probably give you some hint. They may tell you that there is a venolymphatic malformation. They may tell you that these are enlarged jugular sacs, right? And this is cystic hygroma. This is cystic hygroma. Okay. Now, extra bits of information when this is diagnosed, and this is a major anomaly. This is a major anomaly, not like NT, which is just a marker. This is a major anomaly. When diagnosed in first trimester, it is very likely associated with trisomy 21, monosomy X and trisomy 18. When diagnosed in second trimester, associated most commonly with monosomy X, and also associated with cardiovascular anomalies and mainly very specifically hypoplastic left heart, right? So once such kind of a major anomaly is diagnosed, karyotyping, invasive fetal testing, fetal echo, this should be definitely be done. Next image, omphalocele and gastrocysts. Now see, these are the sort of questions that are now being asked. You know, they're kind of integrating your embryology, your anatomy, your radiology and your gynae. So, so you can see here omphalocele is a midline defect. We all know this, right? And it is a midline defect through the umbilicus and it is covered with the membrane. It is covered with the peritoneal membrane, right? So this, if they are giving you an image like this, they will tell you something. They will tell you that it is central. They will tell you that it is covered by a thin membrane, or you will find the cord attached to this bulge here at the umbilicus. This is omphalocele, right? There is increased risk of underlying aneuploidy. So omphalocele is a major anomaly. Omphalocele is a major anomaly. Right. Now, on the right is gastrocysts, right? They will tell you that there is a defect lateral to the umbilicus. If they give you such an image, they will have to tell you some extra information that it is lateral to the umbilicus and there is no membrane covering it. That is gastrocysts, right? Now, gastrocysts, please remember here, very importantly, that there is no underlying risk of aneuploidy. There is no underlying risk of aneuploidy, and this is one anomaly which is seen in fetuses of younger mothers. Another interesting point, right? So gastrocysts, like I said, you are right in mentioning good prognosis because there is no underlying risk of aneuploidy. Gastrocysts is one anomaly which is associated with the good prognosis for the fetus. Okay. So this is the integration, all right. We tend to read such reports in our obstetrics clinics. Now identify the fetal anomaly here. Now see, this is the abdomen. Okay, and this is what we call as the double bubble sign, right? So the double bubble sign you see on the X-ray of a newborn also. There also you will see it. Here also you are seeing this is an antenatal scan. This is an antenatal scan and you can see the double bubble sign. You already know what this is. This is duodenal atresia. This is duodenal atresia. From obstetric perspective, please remember that this is associated with Down syndrome. Okay, this is associated with Down syndrome. Not always, but possibly. Okay, it's the of all the anomalies, this is very, very specific to Down syndrome, and that is duodenal atresia. Next image. Now, in the next image, what are we seeing? We are seeing these images of the invasive fetal testing procedures. So on the first we are seeing amniocentesis. Please remember the timing is anytime after 15 weeks, right? We would do it earlier as well, but now we are not doing it. So timing is after 15 weeks, right? The sample is the amniotic fluid amniocytes and the epithelial and the GI mucosal cells which are suspended in the amniotic fluid. The image on the right is showing chorionic villus sampling. The timing for chorionic villus sampling is 10 to 13 weeks, right? The sample is trophoblast. The trophoblasts are the dividing cells. Reports of karyotyping come much faster with chorionic villus sampling as compared to amniocentesis. Please remember that if it is done early, if early CVS is done, it can lead to limb reduction defects. Limb reduction defects. So early is definitely not done. Right time is 10 to 13 weeks. Chordocentesis is the image on the right where the umbilical vein is sampled. Umbilical vein is sampled, not the artery. If we accidentally puncture the artery, it can cause sudden bradycardia because of spasm of the umbilical artery. So it's always the umbilical vein that is sampled. It can be done anytime beyond 18 weeks. Okay, it can be done anytime beyond 18 weeks. Now, the purpose of these invasive fetal testing is to get the fetal sample. So when we get the fetal sample, we can subject that particular fetal sample to testing for fetal genetic disorders, for aneuploidies, for fetal infections, right? Please remember that chorionic villus sampling cannot detect fetal anemia and neural tube defects, okay? Neural tube defects are structural malformations, and the investigation of choice for neural tube defects is ultrasound. That is the investigation of choice for antenatal diagnosis. For antenatal diagnosis of neural tube defects is ultrasound. Okay, please remember this. With amniocentesis, it is possible to detect fetal anemia. It is possible to detect neural tube defects also. Okay, like acetylcholine esterase levels in the amniotic fluid. These are raised in neural tube defects. Okay, but also please remember that the antenatal investigation of choice for neural tube defects is actually ultrasound. No, not routinely, we are not going to use amniocentesis to diagnose neural tube defects. With chordocentesis, we can definitely confirm fetal anemia because we are taking the fetal blood sample, but we can't detect neural tube defects. We can't detect neural tube defect. That has got, chordocentesis will give no information, okay, about neural tube defects. Next image, identify the fetal anomaly. So this is the frog eye sign. Can you see here? So analyze the gross with the ultrasound images, right? So this is the frog eye sign on the left. This is the Mickey Mouse, like the head of a Mickey Mouse with those large ears, and these are the orbits, just the eyes and the orbits which are, you know, poking out. That is the frog eye sign. So this is anencephaly. Very good. This is anencephaly, right? This is one anomaly that can be diagnosed in the first trimester as early as 10 weeks, definitely by 12 to 14 weeks, right? It is also associated with raised maternal serum, alpha fetoprotein level, face presentation, polyhydramnios, postterm. Why postterm? Because see, the fetal pituitary gland is also absent. Fetal pituitary gland is also absent, right? So fetal, and that is why, you know, postterm, because the trigger for labor which involves the fetal pituitary, that doesn't come. So postterm definitely more than preterm. If there is polyhydramnios, even preterm can be precipitated, but more typically postterm. And pseudo shoulder dystocia as well. Pseudo shoulder dystocia. What is pseudo shoulder dystocia? The head gets squeezed out through an incompletely dilated cervix and the shoulder stuck behind an incompletely dilated cervix. That is pseudo shoulder dystocia, right? Next image, identify the fetal anomaly. As you can now, you will identify, because I have shown you a lemon also, I have shown you a banana also. So doesn't this look like a lemon? If you just place it on the side here, this is the lemon sign, lemon sign. This is frontal bone scalloping. This is frontal bone scalloping. That is the lemon sign, right? And there is a curvature of the cerebellum here, which we call as the banana sign, right? Anterior curvature of the cerebellum. right? So this is what we see in the spina bifida. This is what we see in spina bifida. So identify the fetal anomaly, spina bifida. This image is attached here. This is showing spina bifida in the lumbosacral spine, but we don't expect undergraduate students to identify spina bifida unless there's some extra bit of information given to you, and more so will be told by your radiology faculty. Right. So, Dr. Rafa, it's not like which sign is more specific. It has to be seen in the entire context of the scans. All right. Now, next image, identify the ultrasound finding and spot diagnosis. Okay. Now, you will say, madam, give some clues, because question will sort of come with some clues. Patient came with complaint of no fetal movements for 10 days. Right, scan was done, cardiac activity absent on examination. Identify, yes, this is Spalding sign. Now you get it, this is Spalding sign. What is Spalding sign? Can you see this, the bones of the scalp? They are scalloping, right? Because the decomposition has set in of the brain matter, right? So the bones are overlapping each other. So overriding of skull bones, right? And it generally typically takes about 7 days. By 7 days it should be there. Okay, it will not be immediately seen. So 7 days since IUD, it will be seen. So this is Spalding sign. Very good. Next image, identify the ultrasound finding and spot diagnosis. So ultrasound, again, spot diagnosis always come with clue. All right. So let me tell you, RH negative woman. Okay. And let me tell you, polyhydramnios is also there on scan. I mean, I can think of n number of clues. I'm just giving you clear cut, right? So what is this? This is hydrops, not horseshoe kidney. This is the fetal skull. This is the fetal skull. Okay. And there is this halo around the skull. This is called as the halo sign. This is called as the Buddha sign. You see this and hydrops, fetal hydrops. Okay. So what is there? There is scalp edema. Basically, there is scalp edema. All right. So in fetal hydrops, there should be either 2 effusions that will qualify as hydrops, or there should be 1 effusion plus generalized anasarca. When generalized anasarca is there, okay, we are expecting that there will be scalp edema when generalized anasarca is there, right? So that is what it is, right? So this is fetal hydrops. Okay. Now, overall, please also remember, overall, non-immune hydrops is more common than immune hydrops. When I say RH negative or RH affected fetuses, we are talking about immune hydrops. But overall, non-immune hydrops is more common, and most common cause is fetal cardiovascular system anomalies. Okay. And again, one often repeated question, one fetal infection which is associated with fetal hydrops and fetal anemia is fetal parvovirus. Very good. Fetal parvovirus infection. Other causes of hydrops. Most common, I told you, fetal CVS anomalies. Second most common, chromosomal abnormalities. Aneuploidies. Right? Fine. Now, moving on. Next image, identify the procedure, indication and timing. Identify the procedure, indication and timing. So, procedure is, yes, you have to tell me the timing also. Procedure is cerclage. With cerclage, this is McDonald cerclage. Procedure is McDonald cerclage, right? Indication is there has to be a bad obstetric history. Okay, history of recurrent pregnancy loss in the second trimester, or there will be recurrent preterm births. Okay, suggestive of cervical insufficiency. It is always done in a clinical context, not just like that. Okay, so this is the indication. After that, we will see the patient is going to be pregnant. Okay, if there is history of 3 such recurrent pregnancy losses, we can go for history indicated cerclage. We can go for history indicated cerclage. The timing is between 12 to 14 weeks. Timing is between 12 to 14 weeks. If there is history of 2 such recurrent pregnancy loss, 1 or 2, not 3, she is not qualifying for history indicated, 1 or 2 such losses are there, then we can do ultrasound indicated. Okay, what does ultrasound indicated mean? That now that she is pregnant, she is not qualifying for history indicated cerclage, but what do we do instead? Transvaginal sonography monitoring of cervical length. Okay, and if the cervical length is less than 25 mm, the length of the closed cervix is most important. You can obviously see other signs like the V-shaped cervix, the Y-shaped cervix, the funneling of the internal loss and everything. But what is most important is the cervical length, the length of the closed cervix. So when the length is showing us, okay, that it is about to open up, we can go for the ultrasound indicated cervical cerclage, right? And this is again preferably to be done before 24 weeks, preferably before 24 weeks. Okay. All right. ओके एंड गिव प्रोजेस्ट्रॉन एंड सर्कलाज. बच्चे प्रोजेस्ट्रॉन का क्या है कि अगर सर्कलाज नहीं कर रहे हैं तो प्रोजेस्ट्रॉन दे देते हैं. सो आइदर अ वुमन बिकॉज ऑफ हर हिस्ट्री, आइदर अ वुमन बिकॉज ऑफ हर क्लिनिकल कॉन्टेक्स्ट डिजर्व्स अ सर्कलाज क्लियर कट, एंड क्लियर कट सर्कलाज इज डन है. अब इसमें देयर आर मेनी इफ्स एंड बट्स. रिमेंबर आइदर शी विल बी फिट फॉर सर्कलाज, मेनी टाइम्स इफ शी इज नॉट फिटिंग फॉर सर्कलाज देन वी गिव प्रोजेस्ट्रॉन थेरेपी. Try to remember it like this. Okay, so when you remember it like this, you will remember कि भाई if there is just history of spontaneous preterm birth but cervical length is normal and she is not qualifying for cerclage, then we can give progesterone therapy. Or if there is only short cervical length incidentally diagnosed and no prior bad obstetric history, no recurrent pregnancy loss history, no cervical insufficiency history, then we can give progesterone therapy, right? So remember, she either fits for cerclage clear cut, and if she doesn't fit, then we think about progesterone therapy. Okay, now as you can see, contraindications to cerclage, very important. Fetus is already abnormal, bleeding or leaking or membranes are absent, if she is getting uterine contraction already, if infection is there already, these are contraindications to cerclage. So when do we remove? We remove the cerclage when she is already 37 weeks, or she goes into labor, or she develops bleeding, or she develops leaking PV. Obviously, these are indications to remove, isn't it? Now, also make a note that when there is a history of cervical insufficiency and the os is already open and there's a bulging bag of membranes is seen, at that point in time, McDonald cerclage is technically difficult to do, and in that situation, we sometimes do a rescue cerclage, and that is called as worm's suture. Worm suture or Hefner's cerclage. Okay. Now, abdominal cerclage is called as Benson and Durfee cerclage, and it is generally done if prior failed vaginal cerclage surgery has been attempted and it is not working. Now, abdominal cerclage, please remember here is, if we put an abdominal cerclage, we will not remove it. Okay, it is not removed and patient is delivered by cesarean section. Okay, because we've taken a lot of pain to put an abdominal cerclage with a lot of technical difficulty and everything. So it can stay there for subsequent pregnancy also. We don't need to remove it. Now, lash and lash is a vaginal cerclage procedure. This question has asked only once, but it is the only cerclage that can be done in non-pregnant. It is the cerclage that can be done only in the non-pregnant state. Okay. Now, next image, identify this instrument. Yes. What is this instrument? You identify this instrument. These are cannulas. These are Carman's cannula, plastic cannulas, right? It has got two ends, two openings, can suck in the contents. Now, this is MVA syringe. MVA syringe, yes. So, this has two suction valves. bivalved, right? So it has 2 suction valves. This is MVA syringe. This syringe capacity is 60 ml. It can create a pressure of precisely 660 mmHg. In sometimes questions mention 600 mmHg, that's also fine, right? And this suction pressure is enough to evacuate a uterus of 12-week gestation. Government of India also allows vacuum aspiration till 12 weeks of gestation, and MV syringe can be used till 12 weeks of gestation, right? So remember these pointers regarding the MVA syringe. Identify this instrument here. Extra information about the instrument mentioned on the side, right? The instrument has got no catch or lock. It has these cup like ends, right? The purpose is that if we are grasping the contents inside the uterine cavity with the help of this instrument, because it has no lock, it can be easily opened and closed. So accidentally also, if we grasp uterine wall, we can quickly leave it, right? So it will avoid, and the design is such that it will avoid a uterine perforation, right? So this is the ovum forceps. Very good. We have identified it correctly. This is the ovum's forceps. Next image. A woman undergoing workup for infertility undergoes diagnostic laparoscopy. These are the findings. What is the diagnosis? So see, images from gynae. See, with obstetrics, we can tend to see very direct images, okay? With gynae, most of the, if they are very clear cut direct, that's a different issue, but many times it will be with the clinical context. Now see, when you say PCOS, you are forgetting and look at this. It was a recent question actually in INI-CET, where the ovaries were absolutely healthy. Nothing peculiar about the ovaries except fact the history of infertility, history of maybe irregular cycles was given or something else. So analyze the image, be it a gross image, be it a lap image, be it a ultrasound image, analyze it with the clinical context. Here one is obviously infertility, so you may be thinking about PCOS, but this is that brownish discoloration. Can you see? This is a chocolate cyst. This is endometriosis. This is a chocolate cyst. This is endometriosis. The cyst filled with chocolate color fluid, old blood, hemosiderin laden old blood content. So that is why the answer to this question is chocolate cyst seen in endometriosis. Okay. Now, this is what more images of endometriosis. This is the cyst that we are seeing on ultrasound. Okay, cysts can have various appearances. Endometriotic cysts can have complex appearances also. But if they ask you typically ground glass appearance, okay, this is that patient whose image is here, ultrasound image, and this is what we found on the laparoscopy. This is the chocolate cyst. Chocolate cyst is also called as endometrioma, associated with endometriosis. All right, and look at this endometriotic image on the right here. I mean, this is something in which we see a lot of adhesions. We can see these purplish deposits, fluid filled vesicles, right? The pouch of Douglas is completely obliterated, right? All these adhesions are there. Various deposits can be there on the pouch of Douglas also, and that is why your clinical examination findings will be on PV. What do you find? That the uterus is pulled back, uterus is retroverted, fixed, tender nodules in the posterior vaginal fornix, those sort of clinical findings you find, and this is what the laparoscopic image will look like. So there can be purplish deposits, reddish deposits, which are brand new deposits, or you can see very like gunshot wounds like deposits, which are old deposits. So like you said, Pratyusha is also saying powdery burn deposits and everything, right? So such images can be there for endometriosis also. So you can correlate your images with the clinical examination findings also, and that is a good way to remember them. Okay. Next image. See, in the option we had genital tuberculosis also, right? So genital tuberculosis also leads to infertility. See, genital tuberculosis is a very difficult diagnosis to make. Let me just point it out to you straight away. Until unless there are very clear-cut clinical profile. The clue would be maybe a past history of tuberculosis. Clue would be a past history of pulmonary tuberculosis. That would be a clue. Okay, and history of amenorrhea, hypomenorrhea, right, infertility as well in that setting. So clinical context A becomes important. Secondly, you can see this laparoscopic image, you can see these white tubercles, you can see these white tubercles. So you can have the peritoneum of the tubes of the uterus, the serosal lining studded with white tubercles. Okay, so if this image classic is given, then only you can say genital tuberculosis. And you can also know, you can see that the tubes are also damaged. Tubes are damaged, there's some degree of tubal damage, you will see beaded tubes, right? And sometimes it can be very subtle. Image on the right, I know this for sure that this is genital tuberculosis because the patient was confirmed to have genital tuberculosis because we took a histopath sample from representative samples from the specimen, and then we subjected them to AFB and culture. Like you diagnose, like you isolate mycobacterium in other cases, similarly here also AFB and bactec and everything, right? So here you can see that the tube is damaged, and this is what we call as dried tree branch sign, dried tree branch sign. Okay, a very thickened tube which is looking as if it is a branch of a tree lying dead and dry. So that is why dried tree branch signs, sort of a tongue twister it has become for me. Okay. So until unless some clinical context is mentioned to you, you will not be able to pick genital tuberculosis up just based on the images. So you have to correlate it with the clinical findings and the clinical profile of the patient also. That is important. Okay. Next image. Violin string adhesions on the undersurface of the diaphragm. This can be a straight question. This is Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome. Okay, this can be seen with PID also. This can be seen with genital tuberculosis also, right? The point is that they will say maybe that there is history of PID. They will say maybe there is history of genital tuberculosis. Then they will say that the patient is having right upper quadrant pain, if they want to give you a clinical profile along with this picture. Right, so this is Fitzhugh-Curtis syndrome where there is perihepatitis, and very rightly said chlamydia is more likely. Chlamydia more likely than gonorrhea. Chlamydia more likely. Very good. Okay, now moving on. Next image, dermoid cyst. Okay, so now with the dermoid cyst, what are you seeing here? Your cut section can be there. Okay. See, dermoid cyst will also look, if you just look at a laparoscopic image of a dermoid cyst, no, it will sort of look greenish like. You may confuse it with endometriotic cyst, but generally dermoid cyst is very heavy because it has these solid contents inside. Okay, so it tends to feel very heavy, and when you cut it open, you will see that it is filled with cheesy sebaceous material. Cheesy sebaceous material is very important. As you can see in this image, there are various kind of substances inside: hair, teeth, cartilage. So basically derivatives of all three germ layers, right? Dermoid cyst is what we call as mature cystic teratoma. Mature cystic teratoma. So derivatives of all three germ layers are there, and as you can see here in this image, what I am pointing to is a Rokitansky protuberance, right? The solid protuberance inside. Okay, now this is the hyperechoic nodule. Can you see hyperechoic because it is appearing whiter than the surrounding. So this is the Rokitansky protuberance that you can see on the scan. And what else are you seeing here? White dashes and dots. That's because of the sebaceous material. That's because of the strands of the hair. So here in this image, this is the Rokitansky protuberance, and the rest white dashes and dots. Very classic of dermoid cyst, dash and dot appearance. The other image, so this was the cyst, okay, this was the cyst, and this is the cyst here. Can you see here? Now this is again that hyperechoic nodule, that Rokitansky protuberance, and whatever else is there is hidden. There is posterior acoustic shadowing. Can you see all this blackness? Everything else is hidden. So it is just the tip of the iceberg. Only part of the iceberg is visible and the rest is hidden. This is the tip of iceberg sign, classic of dermoid cyst. So dermoid cyst is one cyst which can actually be, with a fair amount of accuracy and certainty, be diagnosed on ultrasound as well. So on ultrasound we are able to tell that it is a dermoid cyst. Okay. Next image, identify the ultrasound images. Clinical context, history of irregular cycles, maybe history of amenorrhea is given or something else. Maybe history of hirsutism is given. Yes, identify the ultrasound images. Polycystic ovarian syndrome, PCOS. So you see, you have these polycystic ovaries. What is important in polycystic ovaries? The number of follicles is important. So according to the Rotterdam's criteria, originally they said more than or equal to 12 follicles. But the newest ESHRE criteria, forget what ESHRE means, but what the newest criteria is more than or equal to 20 follicles. So we have to count these follicles. Please remember, these are not cysts. You will not find cysts in the ovaries. I keep telling again. These are 2 to 9 mm measuring follicles which are counted. There can be a necklace appearance. There can be a stromal hyperplasia. This marked X is stromal hyperplasia. Okay. But these are not the criteria. Okay, it is the number of the follicles which is important criteria. Keep that in mind. Or another criteria is either the number of follicles is the criteria and or ovarian volume more than 10 ml and or ovarian volume more than 10 ml. Either of the ovary could have polycystic appearance. Both could have polycystic appearance, or either of the ovary could be bulky. Either of the ovary could have a polycystic appearance, right? So remember these important pointers. Identify the ultrasound image. Now you will confuse it with the polycystic ovaries. I can also confuse it with polycystic ovaries, obviously, because all images have to be analyzed in clinical context. The clinical context is history of IVF being done. Maybe ovulation trigger was done with HCG. With IVF, maybe she is getting HMG, human menopausal gonadotropin injection. Now tell me, the woman has got bulky ovaries. She's complaining of pain, abdomen. Yes, this is ovarian hyperstimulation syndrome. The one factor that is responsible for the entire medical manifestation is the vascular endothelial growth factor, which is responsible. So it begins with bulky ovaries, but it has a lot of medical complications because there is endothelial damage in the circulation. So the patient can have pulmonary edema, ascites, hypoproteinemia, and all the medical complications that can happen because of that. Okay, so you need to remember this is OHSS. Okay, fine. Now, Acha, tell me one thing. If I give you the same image, and I tell you the clinical context is that a woman has been diagnosed with molar pregnancy, complete molar pregnancy, and she's also having bulky ovaries, and this is the image that I give to you. What will be your diagnosis then? Same image, but I just flip the entire clinical context. Theca lutein cyst. Yes, Chitesh. Right. No, stostoma appearance, Pratyusha, that I'm telling you. It is a diagnosed case of complete molar pregnancy. The ovaries are bulky and this is their appearance on ultrasound. Then you can tell me that it is a theca lutein cyst because you're analyzing the image in context of the clinical profile of the patient. Isn't it? Right. All right. Next. Look at these images, just plain simple. Post-menstrual endometrial lining is thin hyperechoic line, just a thin hyperechoic line, right? Peri-ovulatory endometrium is a triple line endometrium, and secretory phase endometrium, see, triple line, one single hyperechoic line, and then you have the hypoechoic areas and then another white line. This is because of around the time of ovulation, these glandular epithelium develops, proliferation of the glands happens. So that is because of that. And then secretory phase endometrium on the right showing a thick, all this is thick white, right? So thick hyperechoic with posterior enhancement. These are the endometrial lining images on ultrasound, right? Try to correlate this with these two images also. So like I said that these in the proliferative endometrium, the image on the left is showing proliferative endometrium. So you can see that there are narrow tubular glands and loose syncytial stroma. That's why the hypoechoic areas around the thin white line. So loose syncytial stroma and narrow tubular glands. So I have just made them like a tubule, right? Now here on the other, you are seeing secretory endometrium, right? So now there is more of stromal edema, the glands become tortuous, tortuous glands, right? So you will see corkscrew shaped glands, you will see corkscrew glands, you can see. But the first change, they ask you this question, the first change is subnuclear vacuolation. Please remember the first change. When secretory endometrium, secretory changes come in the second half of the cycle. The first change is basal vacuolation, or which is also called as subnuclear vacuolation. So this is the first change. I'll just highlight it here. Subnuclear vacuolation is the first change to take place. Okay. So this is also an MCQ pointer directly. Next image, 23-year-old woman is seen with the complaint of postcoital bleeding. On per-speculum examination, this is what is the finding, the lesion bleeds on touch. Okay, I have two images for you. One is this is from one of my patients, right? So tell me, what are we seeing here? It's not cervical cancer, it's not Nabothian cyst, and it's not cervical fibroid, it is a cervical polyp. Okay, so this is, can you see, this is bright red. All right, it can be friable, it will bleed on touch because it is the endocervical, it arises from the endocervical epithelium. So this is most likely an endocervical polyp. This is an endocervical polyp. Okay. On clinical examination, it is, we are able to tell because, we'll see the base of the pedicle. Where is this base of the pedicle? Even when I try to put my fingers around the polyp, I can, feel where is the base of the pedicle. Is it coming from the cervix only, right? So that kind of a clinical distinction is possible. It is possible to see that on clinical examination. Now look at the other options. Okay, now this is here a cervical fibroid. This is here a cervical fibroid. So when we were examining this patient, it was like this. This was her cervix. Can you see? This is the external os. It is coming from the substance of the cervix. This is a huge cervical fibroid and the uterus is small, sitting on top. This is the dome on St. Paul appearance, dome on St. Paul appearance of a cervical fibroid. Now what is this? In this patient, when we saw this patient, these are all hysterectomy specimens. So I'll just to give you a context, right? So this is the cervix, this is the os. This is coming from up. This is also fleshy. It is solid. This ball could be held in the hand. This is fleshy fibroid polyp. This is fleshy fibroid polyp which is coming from very high up above. When we did a cut section, it was coming from inside the uterus. It is coming from inside the uterus. Okay, so we had to cut this cut section up and then see it is coming from inside the uterus. The pedicle is high up. So this is a fleshy fibroid polyp. All of these conditions can present with irregular sort of bleeding, heavy menstrual bleeding, postcoital bleeding, and so on and so forth. So abnormal uterine bleeding patterns can be there with both, right? So this is for your, don't get confused between the images. So this is a typical cervical fibroid and this is a fleshy fibroid polyp. Now this is what? Can you see? This is a very magnified view of the cervix. So it's not such a huge cyst on the cervix, but this is what it is. Now I'll have to wait for your responses. So this is the squamocolumnar junction. the new one. This where is must have been the old scomocolumnar junction. This entire zone is called as the transformation zone. On the periphery of the transformation zone, you are seeing these cysts, right? So yes, this is cervical ectropion. Of course, this is cervical erosion and ectropion because the endocervical epithelium is spouting out, but it is completely physiological. All right. So yes, many things we have seen. Cervical ectropion is there, endocervical epithelium is spouting out. We have seen that there is a transformation zone, and these cysts, nobody has answered yet. What are these cysts? Or follicles? Nabothian follicles can be large, then they're called as cysts, Nabothian cysts, physiological. They are physiological. They are physiological. Okay, they are generally seen on the periphery of the transformation zone. So these follicles are Nabothian follicles. Okay, fine. So they basically result when the transformation zone is formed. So transformation zone is squamous metaplasia. Squamous metaplasia happening over glandular epithelium. Squamous metaplasia happening over the endocervical epithelium. So sometimes here squamous metaplasia happening over glandular epithelium. This is the glandular epithelium. This is the squamous metaplasia happening. So sometimes there can be the metaplasia in the crypts of the gland. In the crypts of the gland, metaplasia does not happen. So it gets filled with glandular secretions, mucoid secretions. Okay, and then it appears on the external surface as Nabothian follicles, right? So that is the genesis of the Nabothian follicles. Now, moving on, identify the hysterectomy specimen. Yes, identify the hysterectomy specimen on the left and on the right. Clinical context, multiparous woman, family complete, had long history of abnormal uterine bleeding pattern, whatever, underwent a hysterectomy. So the image on the left, you can see that this is the cut section. Okay, this is the uterine lining. You can see that the posterior wall, one of the wall, most likely posterior wall, is thickened much more, right? And this is some, deposits. Glandular hyperplasia is also, myometrial hyperplasia is also there, but there is no clear-cut tumor or anything. There is no whorled appearance. So that is why they are two kept side by side so that you can compare. Okay, this is adenomyosis. And on the right is fibroid. Leiomyoma, right? So on cut section, you can see that they have a typical whorled appearance. Okay, they have a typical whorled appearance and they are very clearly defined. Okay, they are very clearly defined tumors. However, they have a pseudocapsule. It's not a true capsule, it is a pseudocapsule. They have a whorled appearance on cut section. Okay, fine. So you can see here, this one is intramural, most commonly also intramural. Then some of them are subserosal also, right? So this is the hysterectomy specimen of adenomyosis compared with fibroid on the other side. Now compare the ultrasound images. This image on the left, see, this is the uterus, this is the endometrial cavity lining, and this is a symmetrical, very well defined hypoechoic heterogeneous mass on ultrasound. This is a fibroid. So an ultrasound scan is good enough to make a diagnosis of a fibroid in most cases. Image on the right, you see this is the uterus outline, this is the endometrial lining, and here also this is the outline of the uterus. This is the endometrial lining. What else you are seeing? Can you see these images like the rays of the sun? I'll just delete it. This is the Venetian blind appearance, like blinds on the windows. So this here is the Venetian blind appearance that we are seeing. I had shown you the images of endometrium and myometrium in the just when we saw the ultrasound images of endometrial lining. You could see the endometrium, you could see the myometrium separately. Here, where the endometrium is ending and beginning of myometrium, the clear-cut definition has been lost. So loss of endomyometrial junction. Sometimes you can see these myometrial cysts. They're very specific. They are most specific. Myometrial cysts, indiscriminate endometrium, right? So sometimes we can also see moth-eaten appearance. Sometimes they will also describe it as salt and pepper appearance, right? So these are also all findings of adenomyosis. So here on the right we have adenomyosis. Next image, MRI images. Image on the right, can you see here? How will you identify? Again, this is the uterine lining, endometrial lining. This is the thickened myometrium, and what especially we are going to see is the inner myometrium. So this is the junctional zone. Junctional zone thickness is what we see to be increased on adenomyosis. Adenomyosis diagnosis is made when the junctional zone's thickness is more than 12 mm. If it is less than 8 mm, then the diagnosis is excluded. Okay, in between it is equivocal. We cannot say for sure. Image on the left. This is the vagina. There is a very, this is the uterus. I'm just kind of explaining. I already know the films. What I want you to understand here is, this is one, multiple fibroids are there. Clearly demarcated, you can see multiple fibroids are there. Multiple fibroids, completely huge big uterus. So this here is fibroid. Right. So ultrasound most of the times will make the diagnosis of adenomyosis as well as fibroid for us. But there may be times when we are confused, and then maybe we want to go for an MRI to make the diagnosis. Or let's say, for example, we are planning a surgery for fibroid where we want to really see and really determine how the size of fibroids, where exactly are the fibroids. I'm planning a myomectomy surgery and I want to make sure that I remove every fibroid. I know the exact location of the fibroid. So MRI will serve some utility. MRI will be done when needed. Okay. So yes, it is possible to differentiate between the two with the help of MRI also, right? Now moving on, next image. So people were mentioning, this is an often repeated question. I think I've discussed it in the clinical recalls also. 40-year-old obese woman, intermenstrual bleeding, right? That is your clue number 1. There's a lesion in the endometrial cavity with feeding vessel sign. When one single vessel feeds into a lesion into the endometrial cavity, this is the lesion, this is the outline of the uterus, this is the feeding vessel, and this is hyperechoic. Can you see it appears whiter? It is a hyperechoic lesion also. It is a endometrial polyp. It is an endometrial polyp. This is the hysteroscopy image of the patient. Okay, very friable, right? Arising from the endometrium, looks like the surrounding lining of the endometrium, very friable, right? Obviously, we did a polypectomy for her. Hysteroscopy is the best investigation because see, on ultrasound, we have a suspicion. We confirm and treat on hysteroscopy. So on hysteroscopy, we did a polypectomy. Polyp was removed. It was sent for histopath, and then the final confirmation came that what you removed was an endometrial polyp. That is how it goes, and that is how you are going to remember these images. Next image, yes, next image to help you compare. See, this is the outline of the uterus. This is inside a cavity. See, this lesion, I've circled it also. It does not have a feeding vessel sign. This has vascularity on the periphery, mainly vascularity on the periphery. And look at its texture. It's not hyperechoic. It has a similar texture, heterogeneous texture like the surrounding myometrium. This is a fibroid. Remember fibroid, see, you have to correlate the basic pathology. Fibroid has a pseudocapsule, right? Whorled appearance, pseudocapsule. Periphery is more vascular. That is what you see on scanned images also. So this is a fibroid image. This is the same patient's hysteroscopy. On hysteroscopy, this is the submucous fibroid. Can you see here? On scan only, I was able to tell this is a submucous fibroid. This is a submucous fibroid. This is how it looks. See? On hysteroscopy, much more either fleshy or more blanched like this. Right? So this is a submucous fibroid. Right? So these are important images to identify. Now, spot the diagnosis. You already know this, so we will go quick with this. Fungal pseudo-hyphae seen on the left side, it is a pap smear image where fungal pseudo-hyphae are seen. Pap smear is used for cervical cancer screening. Don't answer pap smear for identification of genital infections. Okay, so pap smear can pick up infections sometimes. Okay, so this is a wet mount. On for fungal infections, we will use a KOH wet mount. Clinical profile can be given: cottage cheese discharge, intense pruritus, splash dysuria, vaginal pH is acidic. Very good. This is candidiasis. So spot diagnosis, candidiasis. Next, spot diagnosis: foul spelling, grey discharge, no pruritus, pH alkaline. Clue cells are seen on wet smear or saline microscopy. These clue cells can be picked up on pap smear also. These are the clue cells that have been picked up on pap smear also. These are basically vaginal epithelial cells which are studded with these gram-negative bacteria. There are no WBCs in the discharge, positive whiff test or amine test. This is bacterial vaginosis. Very good. There's a criteria, clinical criteria. We call it as the Amsel's criteria, right? Gold standard for diagnosis is Nugent scoring. In Nugent scoring, we go for the gram stain. But please remember, in routine practice, this gold standard investigation is hardly ever needed or even done. Mainly diagnosis is clinical. Next, spot the diagnosis. What is this? You can see the cervix. Maybe they could give you the vaginal image also along with it. So they are red dots. This is strawberry cervix or strawberry vagina mentioned to you. Greenish, frothy discharge mentioned, itching mentioned. This is the clinical context. Flagellated microorganism which is seen on the wet smear, right? This is also motile. They can be picked up on paps also. These flagellated microorganism can be picked up on pap smear also. Pap smear also. This is trichomoniasis. Very good. Spot diagnosis, trichomoniasis. Next image. Identify the HSG image. On the right is a normal image. Okay, you can see the uterine cavity, normal. You can see the dye coming out of the fallopian tubes. Okay, spilling of the dye. So identify the image on the left. You can see only one side only the dye is going. This is most likely a unicornuate uterus, right? So unicornuate uterus, only one side Mullerian duct development. Okay, sometimes there may be a rudimentary horn. Sometimes there may be a rudimentary horn also attached. Depending upon whether that rudimentary horn is having some endometrial lining, depending on that whether that rudimentary horn is functional or not functional, and depending on whether that rudimentary horn is connected to the rest of the remainder of the rest of the cavity. Rudimentary horn can have unilateral dysmenorrhea, or they can have a pregnancy in the rudimentary horn. Pregnancy in rudimentary horn. What is that called as? Pregnancy in rudimentary horn of a unicornuate uterus? Cornual pregnancy. It is called as a cornual pregnancy. Okay, rudimentary horn pregnancy. Next image. Identify, okay, another more important point. Unicornuate uterus most likely or highest risk of associated renal anomalies. Associated renal anomalies is there in unicornuate uterus. Next image. Yes, identify the HSG image. Either you will see two cannulas, or they will mention two separate cervix seen on per speculum examination. On per speculum examination, two separate cervix seen. If they mention, then you will say it is didelphys uterus. Then you will say it is didelphys uterus. See, on HSG, we are not seeing whether there is a dip at the fundus or not. In HSG, we cannot tell whether there is a dip at the fundus or not. But for image identification, we have to pick up clues. They will either show you two cannulas, or they will mention two separate cervices seen on perspeculum examination. Then you pick didelphys as the answer. Identify the HSG images here, right? So again, you cannot see the dip at the fundus, no, but you can only guess. You can see here that this angle, acute, you can see this angle much bigger, okay? So you can see acute angle, you can see a bigger angle, and the distance between the horns. Right. So distance between the horns is something on an image can be difficult to measure, less than 4 centimeters. But angle you can see. So if your angle is acute, like image on the left, this is septate, likely septate. I am not sure. I'll say likely. This is likely bicornuate. I am not sure. I'll say likely bicornuate when the angle is obtuse, larger. Okay. Now, so HSG can only give me clues, but I will not be able to 100% differentiate. But 3D ultrasound image is our investigation of choice for Mullerian anomalies. It is now our investigation of choice for Mullerian anomalies. It is possible. You can see two separate cavities. You can see the outline of the uterus. This is the rest. This is the myometrium. Okay, you can see the fundus intact, you can see the dip at the fundus, you can see that this is the septum. So this one here on the left is septate. Okay, now image on the right, you can see this dip at the fundus. Can you see here? You can see the dip at the fundus. You can see this is the endometrial cavity, the rest is the myometrium. You can see that septa also there, and you can figure out the dip in the fundus. So this is bicornuate. So 3D USG can help us differentiate, right? This is our investigation of choice. 3D USG can help diagnose didelphys uterus also. 3D USG can help diagnose unicornuate uterus also. It is only when the ultrasound is not able to pick it up properly. Sometimes the anomalies are very complex in nature. Sometimes they do not tell us very exactly, and we may be confused. Then we can use MRI also. Okay, so MRI will give us a better picture. MRI will give us a better clarity. And final confirmation, 100% gold standard. I mean, there's nothing more than this that we can do. That is to see the uterine cavity and the fundus simultaneously, laparohysteroscopy. So you can see hysteroscopic view showing two separate uterine cavities. That you will see whether it is a bicornuate, whether it is a septate. But here there is a dip at the fundus. If you see a dip at the fundus, it is bicornuate uterus. If you see that the fundus is intact, it is going to be a septate uterus. Okay. Now, next image. Identify these HSG images. Images on the left, image on the right. Image on the left, you can see that there is a bilateral cornual block. Okay. Fine. Now, this could be a physiological spasm, or it could be a true block, right? In fact, genital tuberculosis typically has a cornual block. Typically, genital tuberculosis has cornual block because the cornual area or the cornual recesses of the endometrial cavity, they are involved. And when that happens, especially when the endometrium is involved with genital tuberculosis cases, a history of amenorrhea or hypomenorrhea will definitely be there. So again, you have to think in clinical context, right? So this is a bilateral cornual block. On the right, we are seeing that there is no free spill. This is bilateral distal block. Okay. Now, because we are doing an HSG, I am sure at this point in time, there should be no active genital tract infection, isn't it? That is why I have done an HSG. The context is that of infertility. Context is that of infertility, because in infertility workup patients, we do this HSG as a part of tubal patency testing. Okay, so that is the utility of HSG. Tubal factor infertility, to check for tubal patency, we've done a screening test. So the clinical context is that of infertility. If I'm seeing bilateral distal tubal block, some degree of tubal damage has happened. There may be history of PID, maybe history of repeated episodes of PID may be there. There may be history of genital tuberculosis that may be there. What I know is that whatever acute event has happened because it is now something of a history of PID, right? So this tubal damage now is persisting in the form of what? Can you see these dilated fallopian tubes? All this dye is collecting inside the fallopian tube. Why? Because this is most likely a hydrosalpinx. This is most likely a hydrosalpinx. Okay, fine. So all that from what? From an image and a clinical context. Okay, and whenever you have a situation like this, the next step should be preferably a laparohysteroscopy. And if laparohysteroscopy is not given in the option, then you choose laparoscopy as the answer. I want to know the condition of the fallopian tubes. I want to confirm the tubal blockage also at the same time. And in the context of infertility, if I do a hysteroscopy, it will allow me to look at the endometrial lining also, because the patient has infertility. And if it is actually a cornual block, I may be able to attempt hysteroscopic cannulation. So if it is a cornual block is only here, I may be able to attempt a hysteroscopic cannulation for the cornual block. So better to go for laparoscopy plus hysteroscopy, and then if that is in the options, you pick that as the answer, otherwise laparoscopy. And yes, in laparoscopy, Pratyusha, Rishabh, you are rightly saying, अब laparoscopy तो कर ली ना, we introduce the laparoscope, but what then? Look at the pelvis. What then? Also do a laparoscopic chromoperturbation as a part of the entire thing that we are going to do when we are doing a laparoscopy. So this is the image of laparoscopic chromoperturbation, like you said. Okay, so laparoscopy helps us to visualize the tubes, look at the condition of the tubes, and also help us confirm the HSG finding of tubal blockage, right? So you can see this blue dye, methylene blue dye we use. Okay, fine. And we introduce it via the cervix and push it via the cervix, and we can see it coming out of the fimbral end of the fallopian tube, right? So this is the laparoscopic chromoperturbation. Next image, identify the HSG image and spot the diagnosis. Now again, spot the diagnosis has to be with a clinical profile. Let's do the image on the right first. The clinical profile is, we are doing an HSG. I'll always tell you, HSG we are doing as a part of infertility workup only. So I'll say infert workup. Patient has history of hypomenorrhea also. Patient has history of amenorrhea also, and is having difficulty in conceiving, is infertility. We did this imaging. Okay, I'll give you another clue. Very difficult to introduce sound. Difficult to sound the uterus. Putting any instrument inside through the cervix was very difficult, because maybe there are adhesions inside the endocervical canal also. So many clues I could give you. And then I give you this finding. None of the dye is coming out of the fallopian tube. Mostly dye is remaining inside the uterus only, and there are punched out multiple filling defects. Multiple filling defects. Profile. In the patient's profile, when we did a hysteroscopy as a part of infertility workup, we were able to pick up Asherman syndrome. Okay, but please remember, for the diagnosis of Asherman syndrome, what will be needed? Hysteroscopy. Right? For diagnosis, what will be needed? Hysteroscopy. Please remember that. Okay? Because when you want to see anything inside the uterus, the best would be hysteroscopy. Okay? Now, let's have a look at image on the left. Clinical context. I'll give you infertility. I did it for infertility patient workup. I'll tell you she has also history of abnormal uterine bleeding. She has history of intermenstrual bleeding. But because she was, or during infertility workup, we did HSG. Dye not coming out of the fallopian tubes. Okay, forget about the, so tubal blockage is there. Forget about that. Focus on the filling defect. What is this filling defect? There is a smooth filling defect. It could be a polyp. Yes. It could be a fibroid. It could be a fibroid also. It could be a polyp. It could be a fibroid also. It could be a fibroid polyp. I can only say that there is some filling defect, that's all. I will like to go for a hysteroscopy to confirm. Right? And of course, such patients may have had an ultrasound done. Ultrasound will tell. Okay. Confirm, obviously, we will confirm with hysteroscopy. That will give you a confirmation. We will look at the lesion. But ultrasound can also help. Just earlier, we saw ultrasound images of fibroid and we saw ultrasound images of polyp as well. Right? Now, moving on. Next images. Identify the ultrasound images, spot the diagnosis. Spot the diagnosis. There is some cyst. There is some cyst, some tubular, dilated tubular structure. Okay. Now, until unless they tell you what this dilated tubular structure is, or they tell you a clinical context, you cannot identify. Right? But now you are telling me PID, TB, PID, that is the reason. That is the reason. But spot diagnosis would be a hydrosalpinx. You will be able to tell better if I told you there is history of infertility. I'll tell you clinical examination was absolutely normal. So, no immediate concern. History of infertility, history of PID in the past, multiple episodes of PID in the past. This is tubal damage. And then I'd give you the images. Then you will tell me this is hydrosalpinx. Right? Because this is a dilated fallopian tube filled with fluid, filled with clear fluid. There is tubal damage, there are adhesions. See, these small adhesions. This is the cogwheel sign. Okay, septa inside, those are adhesions, incomplete adhesions. This is what we call as the waist sign, like the waist of a woman. Right? So, you will be able to tell me hydrosalpinx if I gave you this clinical context. Okay, fine. Now, next image, identify the ultrasound images and spot the diagnosis. Now, you will tell me, okay, what are these images? Okay, there is some cyst, there is some mass, some round mass, some round mass. What is this round mass? Is it ovary? Is it near to the ovary? Where is it? You will not know unless and until I tell you something. Isn't it? I'll have to give you a clinical context. The clinical context is amenorrhea, pain, bleeding PV plus minus. The clinical context is UPT positive. Now tell me. Another thing I may tell you that uterus is empty. Biggest clue. First clue, uterus empty. Here is the uterus. Uterus is empty. This is adjacent to the uterus. So, they may tell you in the question, there is a mass separate from the ovary. They may tell you that there is a mass separate from ovary. Most of the time, see, if there is a mass separate from ovary in the region of the adnexa, adnexal mass, with a gestational sac inside that mass, with cardiac activity, obviously it is an ectopic. No doubt about it. But most of the times there will be a complex adnexal mass with a lot of vascularity around it. Tubal ring of fire sign. Ring of fire simply means vascularity around a mass, that's it. Even corpus luteal cyst has a ring of fire around it because it has a lot of vascularity around it. But when I say tubal ring of fire sign, I mean that the mass is seen arising in the tube and it has a ring of fire sign. This is how it is described, but it has to be judged in the clinical context. And then I say that the diagnosis is ectopic, tubal ectopic. Okay, or I can see on the image on the right here, there's a lot of vascularity all around the mass, again ring of fire, but there is an empty sac here. Can you see? This is what we call as the donut sign, looks like a donut, donut or bagel sign. Bagel is a donut. So, then in that context, this diagnosis becomes a tubal ectopic, right? So, it becomes a tubal ectopic, right? Now, Pratyusha with shoulder tip pain, ruptured ectopic pregnancy. Yes, Yes, so ruptured ectopic pregnancy becomes more a clinical diagnosis. Hemodynamic instability, right? A lot of hemoperitoneum. Hemoperitoneum, you may not even need to wait for an ultrasound to detect hemoperitoneum. You have a patient who's collapsed, brought on a stretcher, abdominal distension, fluid distension of the abdomen, amenorrhea, UPT positive. Arey bhai, what scan you need? This is ruptured ectopic. Isn't it? At the most, you do a scan. Chalo, you do a scan, and on the scan, uterus is empty. Rest everything fluid. Clinical profile diagnosis, ruptured ectopic. And obviously, yes, shoulder tip pain. Right? Okay. And if you want more of this, you go back to the video where we have discussed this in clinical lecture. I mean, there is a session on YouTube which I've taken the first session this year, where we've discussed the clinical contexts. Now, identify the image and spot the diagnosis. Yes, identify the image and spot the diagnosis. Nothing, no clue I'm giving to you. It is here. What is this? Yes, there is a swelling. The location is posterolateral, right? Posterolateral in the vulva. Posterolateral on the vulva. This is Bartholin's gland swelling. Okay. If there are no signs of infection mentioned, it's just that it is a swelling there. Okay, it can be a cyst. Okay, and generally if it is not an infected cyst, it may be just asymptomatic or may be causing just symptom. Patient will say that I feel something down there. Okay, but if you have fever, tense, tender, warmth, these are signs of infection. So then it could be an abscess also. It could be an abscess also, right? So remember that, okay? Now, as long as it is cyst, okay, with cyst we can go for Word's catheter drainage, Word's catheter drainage, or we can go for marsupialization, marsupialization. Remember this. Okay, these are two things that we can do. We can go for a Word's catheter drainage. There is a small catheter specially designed for this. It is called as Word's catheter, and marsupialization is the surgical procedure that is done by minor surgical procedure. Okay, in both of these procedures we don't remove the gland per se, but if it is an abscess, it will require incision and drainage. Okay, and obviously appropriate antibiotic covers, appropriate antibiotic cover. Okay, and please remember that most commonly E. coli is the infective agent. Most commonly E. coli is the infective agent. Okay. Next, identify the, oh sorry, these are not HSG images. Identify the images and spot the diagnosis. Yes, so there is a bulge at the introitus. Okay, clue. Bulge at the introitus, clue, stress urinary incontinence, clue, difficulty urinating. She has to push the bulge inside to urinate. Now tell me, what is the bulge? Imperforate hymen is not like that. Imperforate hymen will be a bluish bulge. This is the vaginal rugosities also you are seeing. This is prolapse. But yes, can you see the cervix here? Is the cervix coming out? I am telling you her symptoms also. SUI, this is not a urethrocoele, this is a cystocele. This is a cystocele. This is a cystocele, not a urethrocoele. They will never give you image of urethrocoele. Please, it's very subtle. Forget it. It's a cystocele. Okay, urethrocoele will be here near to the urethra. This is bulge, this is cystocele. Okay, this has a cough impulse. Okay, cough impulse is present. When you ask the woman to cough, this bulge increases. Okay, that is what cough impulse seen, and it is reducible. Okay, it can be pushed inside. That is how woman lives with it. She pushes it inside whenever she wants to pee. And then the image on the right. You will look at this image at a swelling at the introitus, you will feel that it's a cystocele, but they will have to tell you more than that. They will tell you it is arising from the lateral aspect of vagina. They will tell you that it is not reducible. It is a tense swelling, tense cystic swelling. You can't push it back in, right? Lateral aspect of vagina. What is this? Very good. This one here is a Gartner's duct cyst, right? In this swelling here, look at this swelling. In this swelling here, look at the surface of the swelling. It is stretched. The vaginal epithelium is stretched. So the vaginal rugosities are lost in a Gartner's duct cyst. So many clues I have given to you that they may mention in the question. Reducible, arising from lateral aspect of vagina, vaginal rugosities are lost. It's a Gartner's duct cyst. And cystocele, they may tell you that there is a swelling arising from the anterior vaginal wall. There is a bulge from the anterior vaginal wall. That is how they will mention in the question. Okay, some clue they may give you in the question. Next image. Identify, in fact, this is the last image. Identify the image and spot the diagnosis. Now see, this is uterocervical descent. Janvi, Gartner's duct cyst is from the lateral aspect of the vaginal walls because that is what is the location of the cyst. Obviously, if it is too large a cyst, one may feel that it is arising from the anterior wall also. But if there is a cyst anteriorly near the urethral opening, it is going to be a paraurethral gland cyst, if that is what you're getting confused with. So this is uterocervical descent. Whether or not it is procedentia, I don't know. By looking at the image, I don't know if it is procedentia. All I know that the cervix is outside. That much I know. For sure it is 3rd degree uterocervical descent. But I don't know if the fundus is out now. Is the fundus out? What do I know? Just by looking at the image, I don't know. If they tell you that the fundus is also outside the introitus, if they tell you this, we feel this. We feel this mass in between our fingers and then try to feel and judge on clinical examination where the entire uterus is out. If the fundus is also outside the introitus, if the complete vaginal wall is everted out, yes, if they mention this, then I say procedentia. That means 4th degree. Otherwise, I just, for now, it is just cervix is outside. Right? Fine. And what is this thing on the cervix and on the vaginal wall? This ulcer. This ulcer. This is a, yes, what is this ulcer? Ulcer I have already told you. This is a decubitus ulcer. This is a decubitus ulcer. It is a venous congestion ulcer. It is a venous congestion ulcer. Women with prolapse can also bleed from this ulcer. And especially if it is bleeding, one can always think about the possibility of malignancy in this ulcer. Okay, before deciding on such patients, one should always consider whether they have been screened or not. Right, so this is a venous congestion ulcer. The treatment is for before surgery, this ulcer has to be treated. How? By glycerin and acriflavin packing. By glycerin and acriflavin packing, which may be needed for maybe, which may be needed for weeks to even months. Okay, so this has to be done first before doing any definitive surgical procedure for the patient. Sorry, this was not the last image. Okay, image. Chitesh, ring pessary can be used. Are yaar, pessary is again a foreign device, right? And you will just, the pessary is going to rub against the ulcer. I will not use a pessary in this patient. The glycerin, the gauze pieces are, a ball of gauze pieces is made. Patient is taught, put the medicine on and keep it inside. That is what it is done. So this is all pap smear apparatus. So this is the Ayers spatula. We can have wooden spatulas. We can have plastic spatula also. This is the endocervical brush. Okay, when we take slides, we take sample from the eye spatula, we take sample from the endocervical brush also. Okay, and this is for the liquid based cytology. This is for the liquid based cytology. Now this is when we make the slide and we dip it in a fixative, right? This is the conventional pap smear. The fixative is 95% ethanol, right? For liquid based cytology, the fixative is methanol. Okay. In government hospitals, you will realize that you all people are taking conventional pap smear. Liquid based cytology, you will realize that people in private are doing because it is expensive, right? More of infrastructure and all that centrifugation apparatus and everything is required. The advantage of liquid based cytology is lesser number of unsatisfactory smears, and the same number can be, and the same sample can be used for HPV DNA testing also. This is the advantage of liquid based cytology. So if you compare conventional and liquid based cytology, the sensitivity and specificity are similar. They are not different. Okay, the sensitivity and specificity are similar. Now, next important pointer, because again I am giving you this pointer because pap smear is being asked a lot these days, right? One pointer where you can be confused about is, again they are also asking a lot about the WHO screening strategy. Okay. Now, please remember that we have a prior, and we are, and our Indian practice and what our guidelines say, we don't have as such national guidelines, but we have the FOXI guidelines. But more or less we are closer, our practice is very close to what the WHO strategy is. The priority screening age group is 30 to 49 years of age, right? So they are saying prioritize screening women who are 30 and beyond, right? So HPV DNA testing, primary HPV DNA testing, meaning do only HPV DNA testing, is beginning from 30-year onwards, right? And it should be repeated every 5 years. Okay, WHO goes one step ahead. WHO says that in low resource settings, yes, primary HPV DNA testing, affordable primary HPV DNA testing, wherever can be provided, should be provided in low resource settings also. Ideally done every 5 years, but minimum of 2 in a lifetime, one at the age of 35, one at the age of 45, minimum 2 in a lifetime primary HPV DNA testing should be done. Alright, so this is about the priority age group screening. In India, we tend to screen beyond 25 years of age. Okay, now please also remember, if we have to screen before the age of 30 years, okay, for somebody who's between 25 to 30 years of age, if we have to screen, what is our option? PAPS alone. PAPS alone is our option. Okay, and PAPS alone is an option for 30 years and beyond also, but between 25 to 30 years, PAPS alone is the only option. PAPS alone is the only option, right? So second screening strategy is PAPS cytology, and it should be repeated every 3 yearly if it is done. Okay, so women, so from 25 year onwards we can go for PAP alone screening strategy, right? Now there is something called as co-testing. Co-testing is something that just turns out to be unnecessarily expensive, and people are moving, now the current recommendations are to move away from co-testing, right? But you should know what co-testing is, doing 2 tests together, right? So at the same time, PAPS plus HPV DNA testing was co-testing, and because we were doing HPV DNA testing together, co-testing is also repeated every 5 years. The third screening strategy is VIA. If visual inspection with acetic acid is being done, then it has to be repeated every 3 yearly. Okay, then every 3 yearly. All right, fine. Now, so in low resource settings, we can have VIA. In low resource setting, we can even have affordable primary HPV DNA testing every 5 yearly in low resource settings also. But PAPS would be very unlikely to be performed in low resource setting. Why? Because PAPS will always need a patholab and a pathologist to analyze the results, analyze the slides, whichever way the slides are made, whether it is by liquid based cytology or it is by conventional PAP smear, it will need infrastructure. Moving on, image on the left Image on the left, we can see an abnormal area. Abnormal area looks white. Abnormal area looks white. This is visual inspection with acetic acid. How much acetic acid we do? 5% acetic acid we use and we dab it over the cervix. Okay. This is villi. Visual inspection with Lugol's iodine. This same area in the same patient, abnormal area is yellow or orange basically. It does not take up the stain of glycogen. It does not, it does not take up the stain of iodine. So, vaginal epithelium, stratified squamous epithelium has, and ectocervical epithelium is rich in glycogen. Na? So, the normal epithelium will take up the stain of iodine, but the abnormal area won't. So, this is villi. Now, these visual inspection tests, they will allow one advantage. The advantage will be see and treat approach. The advantage will be see and treat approach, or see and biopsy approach. See, biopsy, send the biopsy and treat in the same sitting. So, see and treat approach will be possible again. So, this is comes in very handy, comes in very good for low resource settings. Next, identify the procedure and its imaging. This is the last slide. Identify the procedure and its indication. So, the procedure, looking as if like looking through a telescope into the, you can visualize the external genitalia also. You can see the external genitalia, the vulva, the vagina and the cervix under magnification. This is colposcopy. Okay, it will be difficult to see the endocervix. This is something that we not see. We cannot see the endocervix completely. We may slightly be able to dilate this os and maybe just see it, but we can't. Not for endocervical. Not for endocervical analysis. Please remember, not for not for evaluation of endocervix. Okay, again the idea is the same, that we look at the abnormal areas under magnification. Abnormal areas under magnification, that is why you can see such magnified images. You can see the abnormal area, we can see the abnormal vascular patterns. There is a green filter that we can use to see the abnormal vascular patterns also, right? So, remember here from this image that there can be acetovite areas which are abnormal. On top of that acetovite areas, we can see dilated and tortuous vessels. Dilated and tortuous vessels. Okay, and we can see mosaic. These red areas can form tile-like pattern. We can see mosaic, or we can see big red dots that will be called as punctations. So, these abnormal vascular patterns can be seen, and once you see that, we biopsy. Okay, we either take a biopsy or we do a colposcopy directed leap or a loop procedure, right? So, the utility is to analyze abnormal screening results. So, abnormal screening results are analyzed to look for an abnormal area to biopsy. So, colposcopy directed biopsy. Right? Even when patients present with postcoital bleeding, there also there is utility of doing colposcopy for evaluation, because it allows us to see the cervix under magnification, so that maybe to the naked eye, if we are missing something, it can be picked up on colposcopy, right? So, this is in a nutshell about all the important images and the important pointers, all right. So, with this we have done 3 hours of images, and I hope that apart from the images, some extra pointers I have communicated those extra pointers to you. Those extra pointers, please remember that you should, whenever you see an image based question, my crux of the matter is, in the end I will tell you, is either that image has to be very direct and straightforward if it is coming without any attached scenario. Otherwise, if it is coming with a scenario, don't get too stressed by the image, because many times the answer or the clues will be given with the stem of the question. Okay, because even radiologists don't rely on reports or don't analyze reports without a clinical correlation, don't they? At the end of every report, you will say, please correlate clinically. So always in your questions also, if there is a scenario, whether it is a path slide, whether it is a gross image, whether it is a scan image, whatever it is, it has to be correlated clinically. Because then when you correlate, you answer the answer correctly. If you are kind of swiping images in your brain as to where did I see this, where did I see this, you will waste time. Okay, so better that some image comes with a clinical scenario, then you are able to answer and judge better. Okay, so with this we finish off the lecture for now. Let us not waste any more of your precious time, because 3 hours of dedicated OBS lecture is enough, right? Now you can focus on your dinner, and after that maybe some relaxation, and then get down to studying again. All right, and yes, I will be providing you with the PDFs as well. I mean the same thing, I will send it to you so that you can have a quick recall as well. So good night guys, thank you so much.